In any case with inflammatory low back pain, we have to give all out effort to diagnose whether this is a case of spondyloarthritis, whether ankylosing spondylitis or non-radiographic axial spondyloarthritis. We have to give all out effort. So for this reason, I will go for an algorithm. So I am not going into step 1, step 2, step 3, 4. And during this process, we have to look for some of the spondyloarthritis features that I have already been told previously. These are the common groups of features. Those has been called the spondyloarthropathy feature. You see, inflammatory back pain is nowadays one of the important spondyloarthropathy feature. So now I am going to this algorithm, the Berlin algorithm, which has been the SS modified form. You see, whenever any patient comes with low back pain, this has been changed, the low back pain, because the inflammatory low back pain has been changed to one of the important features in this group, in this box that I am just coming to this. So any chronic low back pain, that is the low back pain for more than 12 weeks duration, and in a patient with age less than 45 and usually in a male patient, then this algorithm works better. Do an X-ray of pelvis, straight they ask for X-ray of pelvis to see. It can be anyway, it can be oblique view, it can be the other views to see the SI joints, then X-ray. If X-ray is positive, that is the 3, 4, 5, then you go for modified New York classification criteria to diagnose the ankylosing spondylitis. If it is negative, then look for the presence of those 11 features, the spondyloarthritis features. These are the spondyloarthropathies, 11 features. Negative X-ray, then look for the features. If there are 4 or more features, then SPA features, then it's diagnose the case as spondyloarthritis. If there are 2 to 3 features with low back pain, X-ray negative, then do HLA-B27. So this is the position of HLA-B27. Do HLA-B27. But HLA-B27 nowadays is just going on rampantly in all patients with low back pain. If HLA-B27 is positive with 2 to 3 spondyloarthritis feature in a chronic low back pain patient, then it is spondyloarthritis. If HLA-B27 is negative, then consider other diagnosis. If there is no spondyloarthritis feature on the right hand side, no spondyloarthritis feature, or only one spondyloarthritis feature, then again here HLA-B27 is important. Again, if it is positive, then MRI. Here is the place for MRI. You do MRI. If MRI shows bone marrow edema, the joint, very subtle changes in the joint spaces, then you diagnose the case as, if MRI is positive, then diagnose the case as spondyloarthritis. If it is negative, then consider the other diagnosis. Again, if MRI is negative, they consider the other diagnosis. So this is the diagnostic algorithm. This is not the classification criteria. The SS classification criteria is this. For the purpose of clinical case diagnosis and treatment, we don't need to go for classification criteria. Classification criteria is for classifying a homogeneous group of people to be included in a cohort of subjects. So I'm not going into the details of this. So there might have some other differential diagnosis. You have to keep in mind this. The acute on chronic mechanical non-specific back pain, sometimes it may be confused with inflammatory back pain, fibromyalgia and myalgia also, and diffuse idiopathic skeletal hyperostosis, that is DISH, osteitis condensus ileae, that is an asymptomatic condition, that is a differential diagnosis in radiological finding, erosive osteochondrosis and Schwann nodes. So these are the other features. I am not going into the details. So in conclusion, Mr. Chairman, sirs, I would like to say that inflammatory back pain is a very limited group of patients among the huge vast majority of low back pain patients. So once there is a patient we get to evaluate or diagnose, then we have to go very systematically by again going from history, physical examination and laboratory investigations, and according to that Berlin algorithm we can reach a definitive diagnosis. But still one thing is very important, not all inflammatory back pain are spondyloarthritis, not even non-radiographic axial spondyloarthritis, because there are the fate of these low inflammatory back pain can be of three types. One is spontaneous resolution over the course of time, another may be converted to axial or any other forms of spondyloarthritis, or it may be diagnosed others other than spondyloarthritis. So thank you, Mr. Chairman, sir. Thank you very much.
Thank you, Professor Mohammad Mujibur Rahman sir, for nice deliberation and enlightening us with the concept and approach of inflammatory back pain. Now I'd like to invite Professor Minhaj Rahim Chaudhary sir for deliberation, his topic, his lecture on management update of axial spondyloarthritis.
এই সোহেল এদিকে আসো এই সোহেল এই সোহেল এটা লাগবে এমন কোন এটা লাগবে এখানে প্রাইস কেমন হয় কপি প্রেজেন্টার আসছে इसके मेन स्क्रीन दे
আচ্ছা ঠিক আছে সবার চোখে ঘুম ঘুম কি যে হবে শুনেন আমি ক্লাসে ঢুকে স্যার সব স্টুডেন্টদেরকে বলি মেরুদণ্ড সোজা করে বসো যার মেরুদণ্ড আছে তারপর একটু কাজ হয় আর আতিক স্যারের একটা স্লাইড আছে ঘুম তাড়ানোর ওইটাও দেখাই তো নানান পলিসি করা লাগে এখন চা কফি তো ভুল হয়ে গেছে আসলে মাঝখানে চা কফি আর নজরুল স্যার এসে গেছে আর অবশ্য চিন্তা নাই এনিওয়ে So it's a pleasure to get the opportunity to be here and to talk before this August gathering. My talk is on management of axial spondyloarthritis. And so it's an immune-mediated inflammatory disease predominantly affecting the axial skeleton. So sometimes we ask, what does it mean, axial? So we have to remember it includes also the SI joints and the hip joints and also the chest. I mean the manubrious sternum and the related bones. These are also included within this framework of axial spondyloarthritis. And so it has been divided into two parts, is important. One is the ankylosing spondylitis. All of we are familiar with ankylosing spondylitis, and now Professor Mujib nicely discussed non-radiographic axial spondyloarthritis. So treatment has got two parts. One is non-pharmacological and another one is pharmacological. And this non-pharmacological treatment, here patient education and counseling is very important. We must not forget, and this counseling should be very simple and clear. So we have to make every patient understand what is the disease, what is its natural course and outcomes, and what are the options for treatment, and the importance of continuation of therapy. Because even if we prescribe our patients DMARDs, disease modifying anti-rheumatic drugs, they continue for weeks and maybe months, but then they stop by themselves. So counseling is very important here. Lifestyle modification again very important. And importance of follow-up visit. This is very important. They should come to a follow-up, because we have to know whether the drug is working or whether patient is having any kind of adverse effects or not. Psychosocial intervention is very important. It's a famous painting and on depression, and in one study they found that in ankylosing spondylitis, anxiety or depression present in 25 and 15% patients respectively. Exercise and physical therapy have got paramount importance, and we must not ignore it. And is it a factor? Yes, the studies reveal that it causes progression of the structural damage. So we must ask our patient to stop smoking. And then vaccination. Vaccination is very important, and in rheumatoid arthritis session, we came to know there are especially, we would like to say, pneumococcal vaccination, influenza vaccination. এই রোগ কি, এই রোগই তো আমি সবসময় চিন্তা করি, লাফায় কেন এটা? না, নিজে নিজে লাফাচ্ছে। অ্যানিমেশনে কোনো চাপ পড়ে গেছে নাকি? প্লিজ একটু এইটা চেঞ্জ করে ফেলতে হবে আমার। ও আমার কিছুই করা লাগছে না, আমি কিছুই করছি না, লাফাচ্ছে। এদিকে আসেন, আমি এটা নিয়ে চিন্তা করি, এই ঘটনাই এটা বের করে ফেলি, এখানে ঢুকাই আমি আমার পেন ড্রাইভ থেকে এটা বের করে ফেলি, অ্যানিমেশনে চাপ পড়ে গেছে। আমি করি, আপনি ধরেন না। I'm very sorry. So exercise and physical therapy have paramount importance, I wanted to tell, and patient should be asked to stop smoking. And then vaccination is again very important. So pneumococcal vaccines, there are two types. One is pneumococcal 13, that is we also call conjugate vaccine, and another one is pneumococcal 23, polysaccharide vaccine. Conjugate vaccine patient should take once in a lifetime. Once in a lifetime, and pneumo 23, that is polysaccharide vaccine, and patient should take it after 2 months to 12 months first dose, and then 5 yearly up to 65 years. And influenza vaccine once yearly. It is a must. It has to be done. And now let's move to pharmacologic therapy. So if we look at this painting, we can understand how difficult the life is of a patient having active ankylosing spondylitis or spondyloarthritis, how difficult the morning is. And what are the available therapeutic agents for axial SpA? NSAIDs, sulfasalazine, infliximab, etanercept, adalimumab, golimumab, setrolizumab, all are TNF alpha inhibitor. All are available in Bangladesh except setrolizumab. And IL-17A inhibitor, secukinumab, available in Bangladesh. And among the Janus kinase inhibitor, tofacitinib, upadacitinib. And let us have a look on the update management recommended by EULAR, ESAS EULAR group. They are very strong group. So although boring, let us have a look, and I'll try to pass it very quickly. So the first diagnosis is after diagnosing. Here if we look, this is the axial spondyloarthritis. The diagnosis is done, and we will start NSAIDs. It is a must. If it is not contraindicated, and then NSAID, any NSAIDs can be chosen if there is no comorbidity. And then if we find sufficient response at 2 to 4 weeks, and just after 2 weeks you try to evaluate, and if you find the patient is responding, then continue for another 2 weeks. And if you find that no, after 2 weeks patient is not responding, then change to another NSAID and look for another couple of weeks, and then try to assess. And this way you have to proceed. Continue, and a bit controversial, I will come later, and this way. And then if no response, then what will happen? So it is purely axial disease. We'll switch over to either TNF inhibitor or IL-17 inhibitor or JAK inhibitor. And then again we will evaluate our patient, and the evaluation for 12 weeks. So after 12 weeks, so there is a measurement tool, activity measuring tool. We call it ASDAS. So if the change is 1.1 or more than 1.1, then we will understand that patient is responding, and then we can continue with the same medication. Now the question will arise, is there any withdrawal or tapering of these expensive drugs? Yes, there are provisions. The recommendation is like, if we find 6 months patient has achieved sustained remission, then we can consider either tapering or spacing of the biologics, and definitely also along with the JAK inhibitor. And now the phase 3, if we find in phase 3 the patient did not respond, again we have to look at these 1.1 changes of the ASDAS score. And then we have to, if the patient doesn't respond, then we will re-evaluate the diagnosis. And if we can confirm that the disease is okay, active disease is there, we can switch over to another biologic DMARD, or our patient was first in biologic DMARD, then we can switch over to JAK inhibitor. And if the patient is on first time on JAK inhibitor, then we can choose one biologic. This way we need to proceed. And then again we look at the changes, 1.1 or more, yes, then we will try to continue. And again after 6 months we shall consider whether we can we can make some spacing or tapering, not total withdrawal, and there are debate. Now let's move to the non-steroidal anti-inflammatory drugs. I think these next few slides are very important for all of us. So all are effective. To assess usefulness, we must continue at sustained doses for 2 to 4 weeks. I have already told. Now the issue is continuous versus on-demand therapy. So nowadays the recommendation is, if continuous is not needed, I mean if the symptoms are under control, then on-demand NSAID is preferred. So these are all NSAIDs and with optimum doses. So what has happened in 2015, JCPAR, they found that they put their patients having ankylosing spondylitis and for 2 years continuous use, because before this the recommendation was that the patient should continue NSAID for 2 years, because the one randomized trial they showed that even NSAID can halt the progression of the disease, can halt the radiologic progression. So at that time the concept was we have to continue NSAIDs. And then this study came out and they said, no, we did not find any kind of cessation or halt the progression of the radiological damage. And then the on-demand concept again came out. Then another meta-analysis, 2020, they also did not find any differences between patients in the NSAID group and the control group at the end of 2 years. And then precision trial, in this trial, they tried to look at the cardiovascular safety of celecoxib, naproxen or ibuprofen, and they didn't find any difference. And then interestingly, before this study, again there was concept that naproxen was superior to coxib, especially etoricoxib and diclofenac in terms of cardiac safety and cardiovascular safety. And this article was published in BMJ in 2011, and they published their results on 31 randomized trials. So it was a huge study. However, when the precision trial results came out, now they are telling, no, there is no difference between celecoxib and naproxen in terms of cardiac safety. So regarding the renal impairment, here 2017 recommendation is like for mild pain we can try with only paracetamol, so topical analgesics, and may be considered Sulindac, again a controversial issue. And for moderate pain, tramadol may be a good choice, and severe pain, methadone may be tried. And if the hepatic impairment is there, so tramadol and especially immediate release, we have to remember, so not the sustained release. We should try to avoid sustained release and start with 50 milligram every 12 hourly and treat, avoid if the patient is having seizure, and avoid constipation. What's about glucocorticoids? So this is very important, I think, for all of us again. So ACR, American College of Rheumatology, they strongly recommend against treatment with systemic glucocorticoids. So here the patients with spondyloarthritis, we should try to avoid systemic glucocorticoids. However, locally administered parenteral glucocorticoids can be tried, but we have to remember peritendon injections of Achilles, patellar and quadriceps should be avoided. And then here another group, so again Asas Euler, they also recommended that patients with axial disease should not receive long-term treatment with systemic glucocorticoids. So I'd like to request our all junior colleagues, if you consider that your patient is having spondyloarthritis, so you don't need to put your patients on systemic glucocorticoids, because I can assure you, if you put even for a short term, if you ask 7 days, 14 days, they will pick up only glucocorticoid, prednisolone or deflazacort, whatever it is, and they will continue it, and after months and years, this patient will come to you with lot of adverse effects. So we have to be very cautious. What's about paracetamol and opioid-like drugs? And definitely it can be considered for residual pain if NSAID have failed or contraindicated and or poorly tolerated or not responding well. So you can add or adjunct as adjunct the paracetamol and even the opioid for the time being, and keeping in mind all the adverse effects. Now what's about conventional synthetic DMARDs? What does it mean? Sulfasalazine, methotrexate, leflunomide. these are the drugs we call conventional synthetic disease modifying anti-rheumatic drugs. So recent recommendation is we have no scope to use methotrexate and possibly leflunomide in spondyloarthritis, I mean definitely axial. But if the peripheral involvement is there, we can try sulfasalazine. Now, when should we consider a biologics or targeted synthetic DMARDs, that is genus kinase inhibitors or JAK inhibitors, tofacitinib, upadacitinib, etc. So the diagnosis is here. Let us start from here. So diagnosis is here. Everything elevated CRP positive, everything is okay in favor. So I have already told all patients should be put on NSAIDs first, 2 to 4 weeks. And after 4 weeks, then you decide. And so there is no response, enough response, then definitely if you find, again this tool is important, measuring tool. You have to measure the activity. So ASDAS we prefer nowadays, ASDAS CRP. So if you find it is 2.1 or more, then we will consider either a biologic or targeted synthetic DMARDs than JAK inhibitors. So I have already showed you the Euler and ASAS recommendation. Now again the question is, so we are planning to put our patients on either tofacitinib or the upadacitinib or a biologic. So should we go for latent TB screening? And Professor Nazrul was trying to tell one study report that the probably tuberculosis is less. But still the recommendation is we have to go for latent tuberculosis screening. So if we consider the scientific way of approaching to our patient, then definitely we should go for that screening. So we have Monto test or the tuberculin skin test or the interferon gamma release assay. But we have to remember that interferon gamma release assay is more specific and more sensitive. And again, interferon gamma release assay are of two types. One is T-spot test, another one is quantiferon TB Gold Plus test. And the quantiferon TB Gold Plus test is more specific. And so if we find it's positive and the chest radiograph is normal, so the diagnosis is latent tuberculosis infection, and we need to treat our patients for latent tuberculosis infection, especially before starting biologics and as well as your JAK inhibitor and tofacitinib too. And so for how long? 3 to 4 months with 2 drugs. We have to remember monotherapy is not recommended in our country, Bangladesh. So at least 2, rifampicin, preferably rifampicin and INH. And after 1 month or 6 weeks, we can start the preferred drug. Now the biologics and JAK inhibitors, dawn of a new era. তাহলে আমি বলি যে বাংলাটা কি হচ্ছে, তাহলে নতুন যুগের সূচনা, সূর্যোদয়. And it's really dawn of a new era. So let me talk few minutes on genus kinase inhibitors. I thought when Professor Nazrul was giving his lecture, I thought all these slides will be similar to me, and I was a bit puzzled what will happen to me. But interestingly, I found he had a lot of other different interesting slides. So I am a little bit relieved. Anyway, so but a little repetition may be there, and it is important. It can be, because these things, you know, when I hear and the study, there is one study too. If you are very attentive, now I understand you are not that much attentive, but even if you are very much attentive and you try to capture or memorize all these things, what I am saying, you will be able only 10 to 20% capturing or memorizing the things. So study showed it. Now, how does they really work? So find here the cytokine, and the cytokine comes here on the cell surface receptor. So here we can see the receptor, they binds to receptor, and receptor dimerization. It means its activity increases, and it activates Janus kinase phosphorylation of the receptor. And we have to remember this Janus kinase mechanism is totally intracellular within the cell. But what about the other drugs, biologics? They work extracellularly, outside the cell. That is a very important differentiating point. এটা দেখা যাচ্ছে না এরোতে? আরে এখন আবার স্যার একটু বাঁকা হইতে ভয় পাই আবার যদি স্লাইড লাফানো শুরু করে। আলো জ্বলে না। Oh, very good, very good. So what is happening here? This cytokine, so first the cytokine is here, it binds to the receptor, the target receptor, and JAK is here, Janus kinase. So what is our target with the drug? Target is we have to inhibit JAK, Janus kinase. And now the Janus kinase, what is happening next? The receptor dimerization activate Janus kinase phosphorylation of receptor. So receptor is phosphorylated. So a complex type formation is here, Janus kinase and receptor. And then this Janus kinase is capable of phosphorylating state. And this state binds phosphorylated receptor first, and then the JAK phosphorylates state. This is important. And then again state activity is increased, and then state, this state dimer, this is phosphorylated state. They are capable to enter into nucleus, and then the natural things, that is the, we know the transcription and translation of protein and etc. etc. All the activities will be there. And this way Janus kinase works. Now how the tofacitinib works then. So here is an example. Tofacitinib is here. So this is the cytokine. Cytokine means it could be tumor necrosis factor alpha or interleukin, anyone, interleukin 17 or tumor necrosis alpha. They come here, there is the receptor. So they are trying to enter. Here is JAK, and in this stage here, when the state is trying to be phosphorylated, our drug tofacitinib will block this pathway. So state will not be activated, not be phosphorylated, not be activated, and they will not be able to enter into nucleus. And then the subsequent processes, transcription and translation will not occur. So Dr. Asad, he is not here. He worked under the guidance of Professor Nazrul, and they have seen that the tofacitinib is effective in these cases. And there are a lot of studies, but we have one. That's why I am citing this example. And what's about the upadacitinib? Again, these are the lots of hizzy-bizzies. So in a nutshell, I am telling, is found to be effective. And what's about the baricitinib? Not yet recommended, principally JAK2, but JAK1 also, but is not currently approved or studied for axial SPA. However, in near future, maybe its potency may be there. So lot of common adverse effects. There is a long list, and the important is the infection. You look 20%. So whenever we are putting our patients on tofacitinib, it's not that like that painkiller. You see, we are prescribing or we are suggesting our patients, okay, take it. But interestingly, I remember when the leflunomide, Jahid, you are sleeping. Leflunomide, when first came in Bangladesh, with the name of Nodia. So it was very interesting. The pharmacy people, they started giving all the patients having pain. But interestingly, it did not work in that way. Pain, so after 1 month, 2 months, pain was not subsiding, and then they stopped selling. And that's why a lot of patients probably saved. But problem is with the tofacitinib. If you really give to your patient, it works like a magic, and within couple of weeks or the 1 month, 2 months, they start getting results. So ব্যবসাটা খুবই রমরমা. Anyway, but we have to keep it in mind that we need to prepare. So we have to prescribe our patients in a scientific way. Otherwise, the prescription টা নিয়ে যখন দেশের বাইরে যাবে, so ওরা বলবে যে এটা সায়েন্টিফিক হয় নাই বা তোমার দেশের ডাক্তাররা ভুল চিকিৎসা দিল। So এটা we have to take care, and so we have to aware of these, all these lot of infection, lot of adverse effects. So infections and other is 1 to 2%, quite cardiovascular, central nervous system, GI, genitourinary, hepatic, renal. So look, ALT increased more than 3 times, serum creatinine, respiratory, and also serious infections may be there. So what's about the all infections like upper respiratory? Professor Nazrul also showed it. Upper respiratory infections, urinary tract infections, nasopharyngitis, occasional diarrhea, herpes zoster, tuberculosis, opportunistic infections. And then there are I couldn't end it. Look, so many problems. So hematologic bone marrow suppression, and then cardiovascular dyslipidemia, hypertension, increased risk of cardiovascular events, venous thromboembolic events. So highest for tofacitinib or baricitinib, maybe malignancy, increased risk of malignancy, particularly lung cancer and lymphoma, reproductive health also. JAK inhibitor, especially filgotinib, was a promising drug for spondyloarthritis too. But nowadays is the one study found that it impairs male fertility. So probably its future is dark. Anyway, and today morning, in addition, weight gain. Today morning I was discussing this issue with Thixer, and then so he showed me his Google Bard. Nowadays he has got a magic Google Bard, so we can get the what I should say, the solution of lot of problems. So we found that yes, it causes weight gain, and our patients are coming to us and they're telling, look doctor, it's working on me, no more pain, I am very fine, but I have really become. So what has happened? Is the drug causing? Probably it's causing the weight gain. So lot of adverse effects. Okay. Cardiovascular risk, again we have to remember, in September 2021, FDA warned about an increased risk of major adverse cardiac events. We call it MACE, cancer, blood clots from tofacitinib. Until more data are available, Assas Euler 2022 task force recommends being restrictive. Above 50 years with one or more additional cardiovascular risk factors, and all above 65 years. So what recommendations now we can do? One thing definitely, if patient can afford, probably we can ask to take biologics. Above 50 years with having cardiovascular risk factors, and definitely above 65 years. If cannot afford, then well, we have to use it very cautiously, and either well score or Padua score, one may be suggested at least for the prevention of venous thromboembolic events. So what are the contraindications when we cannot use? What does it mean we cannot use? So if patient is having any kind of active infection, active tuberculosis, cytopenia, moderate to severe renal impairment, moderate to severe hepatic impairment, and any kind of malignancy. Now biologics, biosimilar and non-comparable biosimilar. So what is the difference between biologics and biosimilar? So biologics, the originator drug, we have only one probably in Bangladesh, that has been brought by Novartis, and is IL-17 inhibitor, Cosentyx, and Novartis group is sponsoring this session. So we are thankful to them that at least one biologic is here. What is biosimilar? So biosimilar is similar to, because the word is here similar. So similar to biologic in terms of quality, in terms of efficacy, in terms of adverse effects. Then how to differentiate? So I prefer to give an example. Suppose you have purchased a Toyota car, both are Toyota car, everything is same, Toyota Sprinter or whatever, nowadays ki chole. Anyway, so the color, but the color is different, only red, one is red, one is blue. So this is the difference, biosimilar versus biologic. And probably we will have one biosimilar in Bangladesh soon, of adalimumab. Anyway, And then now, what's about our drugs? We are using all these drugs nowadays. So this is non-innovative or non-innovative biotherapeutics, we call. And in different countries, you see in India, they call it in a different name. In China, they call it in different names. So these are non-innovative. We can call them non-innovative biotherapeutics. So in axial SPA, again, radiographic and non-radiographic. Radiographics is ankylosing spondylitis. We can use all tumor necrosis factor inhibitors, and I have said all are available in Bangladesh except certolizumab pegol. And IL-17 inhibitor, we have secukinumab. And for non-radiographic, definitely TNF inhibitor and IL-17 inhibitor can be used. How do they work? So we can see here TNF alpha again can stimulate macrophage, endothelium, hepatocytes, synoviocytes, and they are capable of releasing a lot of cytokines and chemokines, and they are capable of increasing more inflammation and eventually articular and cartilage destruction. So here is an example, again, how the TNF inhibitor works. And here we can see the oh yeah, I got it. Okay, here we can see this is the so here is the TNF receptor, and here is the TNF molecule has come. So they are, when they are get attached, so there will be signal transduction. That is, action will be within the cell. And this is the adalimumab. This is the adalimumab molecule, and here adalimumab is capturing TNF. So it cannot come to the cell surface, and there will be no signal transduction. Contraindications, again, active infection, untreated latent TB infection, and heart failure, malignancy, we should not prescribe. And now the IL-17 inhibitor, again, this is also a very potent molecule, and eventually they are also capable of producing all these things, inflammation and etc., cartilage damage, destruction. So I have said IL-17 inhibitors, secukinumab, and they definitely improve all these spinal symptoms, peripheral arthritis, dactylitis, enthesitis, and psoriasis. Here you see the pain reduction. There is one study, so within 16 weeks, secukinumab, that is Cosentyx, can reduce disease activity in AS patients. And here is another study results, and patients remain, 97% patients remain syndesmophyte free. That's a good results. So how to monitor the disease? Definitely patient reported outcomes, so clinical, laboratory, symptom severity and treatment, all these important. We need to ask our patient. And there are several disease activity tools, and I have told already that ASDAS CRP is very popular, familiar with us. Also we can use BuzzDie, and there are ASAS CoreSet, and there are several others. And definitely tapering, spacing, discontinuation. Regarding the tapering and spacing is okay, but the large bodies, they are not yet recommending that discontinuation or stoppage. So these are now the therapeutic agents to newer targets. If you look at the targets, you see the definitely WNT, BMP, ERAP1, even HLA-B27. The importance of HLA-B27 here, and future other potential targets like MMP3, TAP, LMP2, ROR, STAT3, ubiquitin, proteoglycan, so all may be targeted in future. Surgery has a role, so total hip arthroplasty or the replacement should be considered in certain group of patients. So this is my last slide, and thank you very much. So severe pain, and the patient is really helpless. Thank you everybody for patient hearing.
Thank you, sir, for your nice deliberation. Now it is the part of audience. If there is any question on inflammatory low back pain and management of axial SPA. Due to time constraint, only one question will be accepted. If there.
বুঝি আর কি, মানে বুঝি নাই কি প্রশ্ন আর কি, বুঝতে তো প্রশ্ন করতাম না আর কি। না না যতটুকু বুঝছি আমি, ইউ আর টকিং অ্যাবাউট ইনফ্লামেটরি লো ব্যাক পেইন, এইটাই। এবং 3টা আউটকাম হচ্ছিল, 3টা আউটকাম আলটিমেটলি ফলো আপ করে দেখা গেল যে একটা হলো অ্যাঙ্গুলার এসপিএ, আরটা কি 2টা ছিল, আরো 2টা ছিল। একটা ভালো হয়ে গেছে, এক গ্রুপ ভালো হয়ে গেছে, আদার। হ্যাঁ, কিন্তু আমার প্রশ্নটা হইলো, এটা আমি ইনক্লুশন কার্ডে বুঝলাম না, তাকে প্রথম থেকে তো এদেরকে এরা এসপিতে ভুগতে পারতো বা অন্যান্য গ্রুপে ভুগতে পারতো, এটা না প্রথম থেকে তো আমি কেন, পরে কেন এরা ডেভেলপ করবে, পরে কেন ডেভেলপ করে এরা যখন আমি তো শুধু কোমর দেখছি, আমি অন্য কিছু দেখিনি তো, সুতরাং প্রথম থেকে এরা অ্যাঙ্গেল স্পন্ডাইটিস ছিল হয়তো। না আমি বুঝিনি, এই জন্য জিজ্ঞেস প্রশ্নটা করছি।
স্লাইড দেখাতে গেলে দেরি হয়ে যাবে, এই দেরি আর এখন সহ্য হচ্ছে না স্যার। মানে হলো স্যার, মানে এট দ্য অনসেট নিউ ডায়াগনোসিস অফ ইনফ্লামেটরি লো ব্যাক পেইন, তার আর কিছুই নাই, আর কিছুই নাই। তাকে আমরা ফলো আপ করতেছি না, শুধু লো ব্যাক পেইন, ইনফ্লামেটরি টাইপ অফ লো ব্যাক পেইন, ক্রনিক লো ব্যাক পেইন,
অন্য কিছু ছিল না,
না অন্য কিছু ছিল
সেটা বলতে সেটা বলেন না আপনি,
না। ওটা একটা স্টাডির কথা বলতে গিয়ে আমি বলছি। ধন্যবাদ স্যার।
আমি একটা মানে প্রশ্ন না, আমি একটা কমেন্ট করি মিনহাজেরটার উপরে, কারণ একটা বলছো তো না, মানে এক একজনের জন্য একটা করে আর কি। বুঝে ওটা আমি মিনহাজেরটা আমার আসলে কোশ্চেন ঠিক না, আমি একটা কমেন্ট করব। মানে আমার কেমন জানি মনে হয় যে আমাদের এই যখন কাউকে কাইনেজ ইনহিবিটার্স বা বায়োলজিক্স দিয়ে যখন ট্রিট করব, তখন আমাদেরটা খুব রিপিটেডলি রিএমফাসাইজ করতে হবে যে এই পেশেন্টদের আমাদের ক্লিনিক্যালি খুব থরলি স্ক্রিন করতে হবে ফর ইনফেকশনস অ্যান্ড ম্যালিগনেন্সিস। যদি ইনফেকশন থাকে সেটাকে ভালো করতে হবে আমাদের। যদি আমরা কোয়ান্টিফেরন, টিবিগোল প্লাস বা টিবারকুলিন কোনোটা পজিটিভ পাই, আবার রিভিজিট করতে হবে, আবার অ্যাসেস করতে হবে যে কোথাও কোনো অ্যাক্টিভ টিবি আছে কিনা। এপিডিডাইমাস পালপেট করতে হবে, কখনো কখনো এপিডিডাইমাল টিউবারকুলোসিসও থাকে, কিন্তু আমাদের অ্যাক্টিভ টিবি কোথাও আছে কিনা আমাদের আবারও দেখতে হবে। যদি কোনো ডাউটফুল, যেটা কি টিউবারকুলোসিস মনে হচ্ছে না, এক্সরেতে এই ধরনের সূক্ষ্ম অপাসিটি থাকে, অথবা ইভিনিং রাইজ অফ টেম্পারেচার থাকে, ওয়েট লস থাকে, এক্সরে চেস্ট নর্মাল, সেই ক্ষেত্রে এমনকি দরকার হলে মানে সিটি স্ক্যান, সিটি চেস্টও করতে হবে কন্ট্রোল। মানে আমাদের ইন এনি কেস বিফোর এম্বার্কিং আপন টু ড্রাগ ট্রিটমেন্ট, টু ড্রাগ অ্যান্ড শর্ট কোর্স 3 মাসের যে চিকিৎসা ফর ল্যাটেন্ট টিউবারকুলোসিস, তার আগে আমাদের 100% শিওর হতে হবে যে ওই পেশেন্টের কোনো অ্যাক্টিভ টিউবারকুলোসিস নাই। কারণ ল্যাটেন্ট টিবি মনে করে যদি আমাদের লুকানো ইন্টেস্টাইনাল টিবিও থাকতে পারে, যদি কোনো একটা লুকানো অ্যাক্টিভ টিউবারকুলোসিসের রোগীকে যদি আমরা ল্যাটেন্ট টিউবারকুলোসিস মনে করে শুধুমাত্র রিফাম্পিসিন এবং আইএনএইচ দিয়ে ট্রিট করি, তাহলে কিন্তু আমরা কমিউনিটিতে এমডিআর বাড়ায় দেওয়ার একটা ঝুঁকি নিচ্ছি, বিশাল ঝুঁকি। কাজেই বিফোর গিভিং ট্রিটমেন্ট ফর ল্যাটেন্ট টিউবারকুলোসিস উই হ্যাভ টু বি 100% শিওর দ্যাট দ্য পেশেন্ট ডাজন্ট হ্যাভ অকাল্ট অ্যাক্টিভ টিউবারকুলোসিস এনিওয়ার ইন দ্য বডি। এটা হচ্ছে আমার বড়। আর
না না অর্ধেক 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 এখানে একটু ঝামেলা আছে। এই স্লাইডটা আমার মনে হয় না না অর্ধেক অর্ধেক এই স্লাইডটা কি আছে ওই যে যেখানে নাকি গামা ইন্টারফারেন্স করছে স্লাইডটা, এখানে স্লাইডটা ভুল কিনা আমার হয়তো ঘুমাই দেখছি, ভুল মনে হচ্ছে আমার কাছে। ওই যে অ্যাক্টিভ টিভি যে এক্সট্রু করছো স্লাইডটা, স্পুরাম, হ্যাঁ যেটা স্পুরাম করছে, হ্যাঁ এইটা আসলে এটা যদি এইভাবে বলে তাহলে মিস আন্ডারস্ট্যান্ডিং হওয়ার সম্ভাবনা আছে। একটু এক্সপ্লো যেটা প্রফেসর আতিকও শুরু করছিল কথাটা, এখানে ইগরা করার পরে ইগরা পজিটিভ হইলে তারপর চেস্ট এক্সরে করছে, তারপর স্পুরাম এফবি, তো অনলি ফর পালমোনারি টিউবারকুলোসিস। ভাস্ট মেজরিটি হলে আমাদের প্রবলেম হয় ডায়াগনোসিস অফ এক্সট্রা টিউবারকুলোসিস, এটা কোনো ইস্যুই না। এটা কফ কাশি থাকবে, জ্বর থাকবে, স্পুরাম করলে এফবি, এটা কোনো ইস্যু না। ইস্যুটা হলো টু এক্সপ্লোর এক্সট্রা পালমোনারি টিউবারকুলোসিস, যেটা প্রফেসর আতিকও বলতেছিল বলে মনে হচ্ছে। ওইটার জন্য কিন্তু আমাদেরকে এই জিনিসটা, এই স্লাইড দিয়ে এটা কমপ্লিট না, কিন্তু জিনিসটা আমার কাছে মনে হচ্ছে উই হ্যাভ টু, না না উই হ্যাভ টু এক্সপ্লোর এক্সট্রা পালমোনারি টিউবারকুলোসিস বাই আদার মিনস। ঠিক আছে,
Thank you, sir. Now I would like to invite Professor M.M. Jahangir Alam, sir, to comment on these 2 lectures.
আসসালামু আলাইকুম অ্যাকচুয়ালি অনেক লেট হয়ে গেছে আমরা শুরুই দেরিতে করেছি we are very much happy and grateful to Bangladesh Rheumatology Society its president Sir Syed Atikul Haq sir and other officials for choosing Sylhet as their venue of 15th annual scientific conference. We welcome to you all. আমাদের দরজা আপনাদের জন্য সবসময় খোলা থাকবে সিলেটে আপনার ভবিষ্যৎ প্রোগ্রামগুলো করতে পারবেন We are very much shocked having our one of the official Abu Shaheen, Professor Abu Shaheen, who have had heart attack last night. We pray to Allah for his recovery. Our two speakers, all are my teachers, who have presented their topics very nicely and elaborately. First one, Professor Mujibur Rahman sir, evaluation of inflammatory back pain. He emphasizes for evaluation in the history and physical examination mostly. Laboratory investigation will give support, but the cornerstone of evaluation is history and physical examination. And he rightly emphasized on early diagnosis and intervention so that movement limitation may be minimum throughout the life. As the management part, Professor Minhaj Rahim sir presented nicely and a detailed, elaborately. Non-pharmacological management and NSAID still have the pivotal role in the management of spondyloarthritis. We have invented many drugs, biologics, JAK inhibitors and others, but we are waiting to find out a drug which will cure our ankle spondyloarthritis. So we are hoping in future we will have that drug. So thank you all for nice sharing, nice presence. Thank you. Assalamu alaikum.
Thank you, sir. Now I'd like to invite Professor Muhammad Ismail Patwari, sir.
Bismillahirrahmanirrahim. Honorable co-chairperson, respected audience, and first of all I congratulate our two renowned speakers, Professor Mujibur Rahman and Professor Minhaj Rahim Chaudhary, for their excellent talk. And in case of evaluation of spondyloarthritis, it is very important because many patients actually goes to many specialists. Especially in case of spondyloarthritis, just few weeks back, I have came across a patient who have initially visited to orthopedic surgeon, then ophthalmologist with the back pain and the back pain as well as the arthritis. Subsequently, when there is a blurring of vision, he goes to the to the ophthalmologist, and they treated with similarly, that is iritis, they are treated with their own way. But then he reported actually to me, just I take the history and evaluated that was a case of spondyloarthropathy with iritis. So this patient at the verge of loss of vision. So proper evaluation, as Professor Mujibur Rahman told us, proper evaluation is very important. The history taking as well as examination, and then actually the investigation which will support us. But actually we depends much more on investigation, and we treat the reports, not the patient. So this is the problem. So we should be very much careful. And regarding the management of spondyloarthropathy, it is also very important. And there are new avenues actually, as we have already learned, that is not only the newer drugs which is already mentioned, that is janus kinase inhibitor as well as the and that is tumor necrosis factor inhibitor, as well as the IL-17 inhibitor, there are many drugs. But choice of drugs is important, and selection of patient is also very important. And already the discussion came. So we are frequently, even at the just general level, we are using the Janus kinase inhibitor because these are very much commonly available drugs. But the algorithm already been shown by Professor Minhaj Rahim Chaudhary. This is very important. And when we would advise the Janus kinase inhibitor and whether we are monitoring this patient properly, that is very important. So I think our trainee doctors will follow these lectures, and if we follow this proper way, this algorithm, we can give some benefit to the patients. Otherwise, this patient actually leads a very miserable life. So thank you very much, our speakers, and also I thank the Bangladesh Rheumatology Society for choosing Sylhet as a venue for the 15th annual conference. Thank you very much for your patience here.
Thank you, sir. Now I'd like to request the chairpersons to hand over the crest and certificate to the speakers. Now I'd like to request Professor Syed Atikul Haq sir to hand over the certificates to the chairpersons.
Sir, Dr. Jahid Al-Qadir nicely moderated the session. I request Atik sir to give certificate to Jahid Al-Qadir. Thank you very much, dear audience. The last but not the least, the session of musculoskeletal ultrasound. You have seen the diversity of the rheumatology. And there are different spectrum of rheumatology already established. In the following lectures, you will find some diversified aspects of the rheumatology. In this session, there are 6 speakers, and chairpersons of the session is Professor A.F.M. Nazmul Islam and Dr. A.K.M. Johir Ahmed. May I request Professor A.F.M. Nazmul Islam sir and Dr. A.K.M. Johir Ahmed sir to take this seat in the dais. And our the moderator is our beloved Professor Minhaj Rahim Chaudhary. I request sir to conduct the session.
So thank you, and I hope it's going to be a very exciting session, and is a different one. It's not a mere lecture, rather to gain some knowledges and to some extent also development of insights into musculoskeletal ultrasound. And my feeling is like that if you have really interest on this subject, so I would request to stay, and definitely after that we will go for another very attractive referral draw. And I would like to request, I think we have in this session we have a number of speakers. And Dr. Mahbub, I will request Dr. Mahbub also to assist me. And the first speaker is probably Dr. Nahid. And Nahid, please, Dr. Nahid Jaman, he will talk on a specific scopes, I mean the scopes of ultrasound, musculoskeletal ultrasound in rheumatology practice. Okay.
Honorable Chairpersons, respected teachers and ardent audience, Assalamu alaikum. It's my great pleasure to say something about the scopes of musculoskeletal ultrasound in rheumatology practice. We all know the imaging technique plays a great role in diagnosing, assessment and monitoring the different conditions. And nowadays, musculoskeletal ultrasound is taking its role in diagnosing, assessment of different rheumatic conditions and also in monitoring the different rheumatic diseases. The advantage of musculoskeletal ultrasonography is it is readily available, non-ionizing, lower cost imaging modality, can essentially detect, localize and characterize most of the soft tissue lesions, recognized as useful imaging technique in the interventional radiology, and by following the needle we can do a lot of interventions, musculoskeletal interventions. There are no absolute contraindication of musculoskeletal ultrasonography, but there are some limitations like operator dependent technology. Deeper structures are difficult to visualize as the higher frequency transducers have lower tissue penetration. Could not visualize the internal structures beyond the bone, and examination of multiple joints at a time is time consuming. And here it is a problem in doing the musculoskeletal ultrasonography. If it is not done properly, the normal structures can be found as pathological structures. That is called anisotrophy. So we have to be careful enough to do the ultrasonography. A lots of indication in musculoskeletal system of ultrasonography. In rheumatology practice, inflammatory joint disease is our concern. So to see the inflammation, musculoskeletal ultrasonography, grayscale image with power Doppler is very much important. And here is a structure of joint, that is knee joint. And first of all, I want to show you in sonographic image, the pathological findings would be like this. This is effusion, that is fluid will be seen as anechoic, that is black. The synovial membrane and synovial preparation would be hypoechoic, and the bony structure will be hyperechoic continuous, and the suprapatellar fat like fatty tissue would be a bit hyperechoic. And this is the cartilage. Here is the cartilage line, and this is anechoic. To realize the pictures, you have to know the structures, how it looks in ultrasonography. And this is the bony contour. And also, from musculoskeletal point of view, bursa identification of bursitis is also important, and it is also anechoic. Ligaments is hyperechoic and fibrillar, but a bit thinner than tendons. And tendons is fibrillar structure in longitudinal appearance and broom end pattern, ঝাড়ুর মাথা এটার মতো লাগবে হচ্ছে if we do in transverse image. And this is the retinaculum. So both articular and periarticular structures could be identified by musculoskeletal ultrasonography. What is the importance or what are the scopes of musculoskeletal ultrasonography in evaluating the early arthritis? And it is a journal that has been published in BMC, the importance of ultrasonography in identifying and differentiating patients with early inflammatory arthritis, a narrative review. Here we can see that if a patient comes to us with early arthritis and there is no convincing clinical symptoms to differentiate into single disease, by doing the ultrasonography we can differentiate it in different musculoskeletal diseases like septic arthritis, spondyloarthritis, polymyalgia rheumatica, rheumatoid arthritis, gout, and etc. And there are musculosonographic characteristics. By seeing the different sonographic characteristics, we can identify the septic arthritis, spondyloarthritis, crystal-associated arthritis, polymyalgia rheumatica, and also septic arthritis. In rheumatoid arthritis, there are criteria and also some X-ray findings and clinical findings. Along with this, by ultrasonography, we can see something that by seeing these features, we can diagnose this is a case of rheumatoid arthritis like synovitis, tenosynovitis, and bone erosion. And here is the Euler-Omerat classification criteria. By doing this criteria, we can identify and we can make a grading of synovitis. That is, if there is synovial hypertrophy along with a single power Doppler image, that is minimal synovitis. If there is synovial hypertrophy with two power Doppler image, power Doppler signal, that is moderate synovitis, and if it is 3 or more, then severe synovitis. And here is a picture of hip joint, and we can easily identify there is effusion. Erosion can be identified by seeing the discontinuity of bony outline. In osteoarthritis, it plays a great role in diagnosing the osteoarthritis, and there are many articles of sonography picture to diagnose the osteoarthritis. By seeing the cartilage thickness and echogenicity of cartilage, we can stage the osteoarthritis picture. This is medial femoral condyle, sulcus of the femoral condyle, and lateral femoral condyle, where initially it was a bit hyperechoic, then gradually more hyperechoic, and there is also reduction of the joint space. And by seeing the osteophytes, and osteophytes is this is step up, and by seeing the osteophyte, grading could be done in case of osteoarthritis. And synovial hypertrophy along with powder signal, it could be identified, and also popliteal cyst could be identified by ultrasonography. There is role of diagnosis of gout and monitoring the treatment of gout. In acute gout attack, there is snowstorm appearance. Snowstorm appearance. We have shown that the effusion, that is collection of fluid in joint cavity, is anechoic, but here is the snowstorm appearance in acute gout attack. We know there is differentials in gout. It may be septic, it may be gout or acute inflammation of other polyarthritis, but in case of acute gout, the sonographic picture would be like this. The assessment of treatment of gouty arthritis is possible by musculoskeletal ultrasonography. Here we can see the double contour sign. Double contour sign is there. Initially, from the diagnosis, the double contour sign is prominent, but with treatment after 3 months, the double contour sign is gradually reducing, and at the end of 6 months, the double contour sign is abolished. So, by doing the musculoskeletal ultrasonography, treatment response could be seen by sonographic images. And here is intra-articular tophus. Intra-articular tophus at the beginning and after 3 months and then after 6 months. CPPD crystal and in hyaline cartilage and fibrocartilage could be identified by musculoskeletal ultrasonography. Here is intra-articular crystal deposition. This is CPPD crystal in hyaline cartilage and here is in fibrocartilage. So by doing sonography, CPPD crystal could be identified, and we also can differentiate between MSU crystal and CPPD crystal. In spondyloarthritis, musculoskeletal ultrasonography plays a great role because enthesitis is important in diagnosing the spondyloarthritis. And by ultrasonography, by power Doppler signal, hypoechogenicity, thickened enthesis, and enthesophyte and erosion could be identified by musculoskeletal ultrasonography. Here is hypoechogenicity along with erosion in enthesis, and there is hypoechogenicity and also taking the power Doppler signal, that is inflammation is there. There is increased thickness of Achilles tendon. It could be identified by musculoskeletal ultrasonography. If the measurement is more than 6.2 millimeter, we can identify this is a case of Achilles tendinitis. Enthesophyte could be identified by musculoskeletal ultrasonography along with inflammatory pictures. Plantar fasciitis could be identified by musculoskeletal ultrasonography. If the thickness is more than 4 millimeter, then we can tell it this is plantar fasciitis. Sacroiliac joint could be visualized by musculoskeletal ultrasonography. Even inflammation could be identified by musculoskeletal ultrasonography. Also in therapeutic purpose, guided injection could be done. Here is important slide, that is muscle imaging. Muscle imaging could be done by ultrasonography, and here is a journal, that is inflammatory myopathy could be identified by musculoskeletal ultrasonography. Here is normal muscle structure, feather or vein on leaf pattern and in transverse steroid pattern. And there is scoring system, Hackmart scoring using vastus lateralis ultrasonography. If there is increased echogenicity and architectural loss with attenuation of deeper structure is found, accordingly, then the grading could be done by musculoskeletal ultrasonography. Here is the structures of vastus lateralis. Here in Hackman grade 4, the bony architecture could not be found, and there is increased echogenicity in different stages. And this is dermatomyositis, transverse image of dermatomyositis where subcutaneous hyperechogenicity along with hyperechogenicity of muscles. But in inclusion body myositis, there is no hyperechogenicity, normal echogenicity in subcutaneous tissue, but there is hyperechogenicity and fibrosis in muscles. So in this way, we can identify the dermatomyositis and inclusion body myositis. There are a role of ultrasonography in systemic sclerosis like synovitis, tenosynovitis, in case of arthritis. Digital ulcers and its deep depth could be identified along with any infective focus could be identified by ultrasonography. The lung, if a patient with systemic sclerosis having DPLD, by doing ultrasonography, we can find out the DPLD. And skin thickness. By seeing the skin thickness, we can find out the severity of systemic sclerosis. In vasculitis, musculoskeletal ultrasonography plays a great role because we know in vasculitis there is information of vessel, and it is found that in grayscale image there is increased thickness of intimal layer, and by power Doppler signal there is also a thickening of intimal layer, and there is stenosis also. And in giant cell arteritis, in transverse image of temporal artery, we may found the hollow sign. By seeing the hollow sign, we can identify the giant cell arteritis. In Takayasu arteritis, there may have macaroni sign, that is homogeneous mid-echoic circumferential wall thickening together with stenosis. We can find it in Takayasu arteritis. By seeing this picture, we can identify Takayasu arteritis. In polyarteritis nodosa, by grayscale image, we can see the image aneurysm. There are 4 aneurysm, and also it could be found in power Doppler images. If there is occlusion of the vessels in systemic sclerosis or other vasculitis, it could be identified by musculoskeletal ultrasonography. Vascular image is possible. And there is also role of ultrasonography in seeing different pathologies in lung, because there is good relation of manifestation in different rheumatic condition like DPLD. Here is A line, this is normal, and it is B line, that is abnormal. In DPLD, we can identify the B line, and we can suspect this might be a case of DPLD. Here is the HRCT image, and here is the ultrasonography image. As infection is common, pneumonic consideration could be identified by ultrasonography. Also, effusion can be identified by musculoskeletal ultrasonography. So, this is the take-home message. Musculoskeletal ultrasonography is very important tool in diagnosis, assessment, and monitoring the different musculoskeletal conditions. With the advancement of transducer, the image quality is improving. In contrast to MRI, CT scan, X-ray, MSK ultrasonography is taking its position to evaluate rheumatic diseases. Along with grayscale image, power Doppler application can identify the severity of inflammation. Nowadays, musculoskeletal ultrasonography is taking the role as the stethoscope of rheumatologist. Thank you.
Thank you, Dr. Naiduzzaman Sajjad, for his nice deliberation on scope of musculoskeletal ultrasound in rheumatology. Our next speaker is Dr. Muhammad Masudul Hassan. He will talk on ultrasounds of hand joints. I will request the speakers to try to complete within 10 minutes as we have time constraints. Thank you.
Thank you very much, Mahbub. Respected chairpersons and dear audience, our focus is to show you the dynamicity of ultrasonogram in diagnosing wrist pathologies. So these are the sounds that we can hear. Ultrasound is the sound which is more than 20 kilohertz, and it cannot be heard by normal human ear, that we detect by ultrasound probes. These are the structures. Before going to ultrasound examinations of the wrist, you have to have very vast knowledge of anatomy of these structures. Then you have to go for finding the pathologies. I'm not going through this because we have a very limited time. So one thing I want to show here is that in the extensor tenosynovitis, there are extensor digitorum tendons. If you see here, this is the extensor digitorum tendons, and if we see, these are the tendons of each digit, and there are some black areas around the tendons, and these black areas are anechoic fluid. When there is tenosynovitis, these anechoic fluids causes swelling of the hand, dorsum of the hand, and if we put our Doppler signal, there will be some Doppler activities that will show this is inflammatory. So we can find out the tenosynovitis by doing ultrasonogram very easily. Now, this is decoherence tenosynovitis. What is decoherence tenosynovitis? I think you all know very well. The first compartment, and see here the abductor pollicis. আমার মনে হয় তোমাদের সাউন্ড সিস্টেমে কোনো ঝামেলা হচ্ছে, হ্যাঁ ঠিক করে দিয়েছেন একটু। ইকো হচ্ছে তো extensor pollicis brevis. Here the extensor pollicis brevis tendon, and around the extensor pollicis brevis tendon there is fluid around the tendon, and also while we put the Doppler signals, there is marked Doppler activity, and that is a grade 2 to 3 Doppler activity, which shows that this is decoherence tenosynovitis, and this ultrasonogram can also give us anatomical site to identify the sheath, and we can put the needle here, and we can give steroid, and the patient will feel free from the pain and inflammation. Now here is extensor carpi ulnaris, which has a very clinical importance in rheumatoid arthritis. Rheumatoid arthritis, this extensor carpi ulnaris tendon, while we see it is a normal extensor carpi ulnaris tendon in our ultrasonogram machine in rheumatology department, there is hyperechoic dots, and these dots are the tendon fibers we see here, and this is a normal tendon, and when we will see there is enormous fluid, hypoic anechoic fluid around this tendon, there is tenosynovitis of this extensor carpi ulnaris tendon, and this will give you a pain diagnosis of tenosynovitis of the extensor carpi ulnaris tendon. Now one very crucial joint is metacarpophalangeal joint, first MCP joint, and this first MCP joint swelling is sometimes we found from osteoarthritis as well as inflammatory arthritis, and sometimes we didn't get the lab support, RA, anti-CCB, these things came negative, and if we see ultrasonogram picture, look, this is inflammatory. There is anechoic synovial hypertrophy, hypoechoic synovial hypertrophy, anechoic fluid, and marked Doppler activity, and also there is a erosion. Here is an erosion. So this is an inflammatory arthritis. And what happens in osteoarthritis? Look, here is mild synovial hypertrophy with mild fluid and a osteophyte. An osteophyte is there. This is the osteophyte. So you can diagnose osteoarthritis of the first MCP joint as well as inflammatory arthritis also. Here is a patient in our department. This patient came to us with suspicious clinical history, and we found this patient has mild synovial hypertrophy here. But look at this picture, there is subcutaneous edema, and also when we put Doppler signal, we found one grade 1 Doppler signal, and this patient have tenosynovitis as well as subcutaneous edema with MCP joint inflammatory arthritis. This is oftenly we see in psoriatic arthritis. So you have to clinically correlate. Don't become smart with ultrasonogram. Always try to clinically correlate the findings. This is our radiocarpal joint, and see radius and lunate and capitate. You can identify the every carpal joint by your probe. And very nicely you can find out the erosion also. And see, here is, this is the anatomical structures with one scan, there is radiolunate and capitate, in another is transverse, here scaphoid and lunate. And if we see in a pathological joint, there is synovial hypertrophy and also fluid, and there is marked Doppler activity. So when you are in clinical dilemma, you can use the ultrasonogram to confirm the diagnosis. And a patient came to the rheumatology OPD with negative rheumatoid factor and anti-CCP. And here we found the inflammatory arthritis findings of the patients. And this is the volar aspect of the wrist joint, where the most important bulk is the profundus and superficialis. And you have to know the anatomy of these structures and also the small bones and their proximal row and distal rows, and you can look at them, and there is also in the similar way you can identify the inflammatory arthritis as well as tenosynovitis. This is the radiocarpal joints in the volar aspect. Here in one patient, usually gout is not, wrist is not a common site for gout. But look at here, what Dr. Naid shows, that is present in this picture in our radioscaphoid joint. There is a double contour sign. So you have to clinically correlate that this can be a gouty arthritis, and this double contour sign is very specific for gout. And TFCC tear, sometimes in trauma, sportsmen come to us with pain in the lateral side of the wrist joint, and if you put the probe, you can identify the TFCC tear. This is the TFCC fibrocartilage. There are hyperechoic dots, and there is a fracture. TFCC is teared down by anechoic areas in between two fracture part of the TFCC. So it is very easy to diagnose. If you know, you have the anatomical knowledge, you can also diagnose this. Ganglion is most common findings in the wrist. There are some ganglion which has communication with the joints. Some are attached to the tendon. So there is, this is usually an anechoic area, rounded area, that is ganglion. And after getting the ganglion, you have to look at the joint whether there is any other pathology or not. And also for tenosynovitis. And carpal tunnel syndrome is one of our very important findings we found in by our ultrasonogram machine, and we have to identify the primary from the secondary. This is one finding where there is primary carpal tunnel syndrome, nerve is involved, and there is thickening of the nerve, and this is the nerve, median nerve, and here see, nerve is not thickened, but the patient came to us with the complaint of sign symptom of carpal tunnel compression, and here is the flexor digitorum profundus and superficialis tendons, all around them there are fluid around, and it is a very tight compartment. That is why this fluid presses the nerve and give the impression of carpal tunnel syndrome, and this is secondary CTS. And you can measure it by measuring. If it is more than 10, then you can say there may be a median nerve thickening, and you have to go for the different DDs. There are many DDs. And there are, in our department, we found a patient with secondary carpal tunnel syndrome. We found enormous fluid around the tendons. Trigger finger is another very critical thing. We put needle in different side without knowing the anatomy. Actually, you have to put the needle in the A1 pulley. There are some pulleys, some crossed pulley and some circular pulleys, and you have to give the needle in the A1 pulley, that is the round pulley, where there is the thickening occurs, and also sometimes nodule found. And in ultrasound, you will get this anechoic area above the tendons. And you have to put the needle and you have to give the steroid there. This is the trigger finger. Dactylitis and arthritis I have shown in the first MCP joint. This is the typical dactylitis and arthritis ultrasonogram picture. And a patient with this type of pain in the digit came to us. We identified there is mild synovial hypertrophy with subcutaneous edema and some dots of fluid in the tendons and also in the subcutaneous tissue. And we diagnosed the patient clinically suspected and sonographically suspected. And we take the history, and that patient was a case of psoriatic arthritis. Now, what is the message? Message is, don't be over smart with ultrasound machine that you can diagnose everything by ultrasound machine. Clinical decision is the core of our rheumatology, and you have to correlate with the investigation. Look, if you see this picture, you can say this is synovial hypertrophy. There is anechoic fluid, hypoechoic synovium, but this is not the fact. It is a case of tumor, myosarcoma. So be alert before giving a confirmed diagnosis by ultrasound. It cannot diagnose anything confirmative. So you have to put a needle, you have to take the biopsy, and you have to send it to a histopathologist, and then you have to confirm this is the diagnosis. So my message is don't be over smart. And this is the site where from I prepared this lecture. Thanks for your patience hearing.
Thanks, Dr. Thanks, Dr. Mohammad Masudul Hassan, for his elaboration on MSK ultrasound of hand. Next speaker is Dr. Muhammad Ariful Islam. He will talk on ultrasound of shoulder joints.
Hello. Dear chairpersons, honorable chairperson and dear audience, good afternoon. Assalamu alaikum. প্রথমে আমি আমাদের শাহিন ভাইকে একবার মনে করতে চাই, কারণ শাহিন ভাইয়ের সাথে আমরা দীর্ঘদিন ধরে কাজ করি। আমরা সবাই ওনার জন্য দোয়া করি যেন তাড়াতাড়ি আরোগ্য লাভ করেন। Anyway, ultrasound of the shoulder. So ultrasound of shoulder, before going to discussion, that ultrasound shoulder is that shoulder joint is a superficial structure, so it is susceptible to both traumatic and non-traumatic injury. And there are some advantages of ultrasound that it is easily portable, absence of radiation and dynamic testing we can do. And there is some disadvantage that we cannot see interior to bones or calcified tissues. And intermediate lesion we cannot diagnose with the ultrasound. And all for understanding well the ultrasonogram, we should know the anatomy of shoulder very well. And all these structures should be both in short and long axis. And a high frequency probe, 12 to 5 microhertz linear array transducer should be used for ultrasonography. So I divide my lecture in shoulder anatomy, then standard scan, probe and patient position, ultrasonography finding, shoulder pathology, and conclusion. So just skip to this slide. That we know that that shoulder joint there is a granite fossa. And the head of humerus. The head of humerus is larger than the granite fossa, so it needs extra support from the other muscles, like rotator cuff. So there are four rotator cuff muscles, which all are seen from this slide. That is supraspinal muscle. Then is subrectum, subrectal bursa. In the posterior, you can see the infraspinatus status minor. This supraspinal, this is subscapular muscle. So it is strongly recommended to examine the patient while seated on a revolving stool, and we should do the scan in the anterior, lateral, and posterior scan. The basic objective for each steps are to identify the tendon of interest, image the tendon in two planes, and ultrasound probe should be perpendicular to the structure that we scan and diagnose the disease. So these are the structure that we usually scan in case of ultrasound of the shoulder. They are the biceps muscle and the rotator cuff muscles, both in longitudinal and transverse scan, and the activator joint, granular joint, and the sacral subductor bursa and supraspinatus and spinal notch. So we scan it in the anterior scan, anterior, lateral, and posterior. Anterior you see supraspinatus, subscapular muscle, supraspinatus part of, and the acromioclavicular joint. The patient position is sitting in the shoulder in neutral position. They will flex to 90 degrees and the hand is supine on the thigh. In anterior scan, shoulder should be hyperextended, internal rotation, dorsal of the hand resting over the lumbar spine. And we see in the anterior scan supraspinatus, infraspinatus, and subacromial subductor bursa. And posteriorly, we can see the infrasternal tendon and posterior granular recess. So these are the position. Actually, we have to. This is the transverse scan showing. Here we can see that this is the biceps tendon, this is the greater tubercle and lesser tubercle. Then this is a longitudinal scan, the biceps tendon. This is biceps tendon longitudinal scan, and If I put the probe in this position in this space, the subsquare muscle, longitudinal axis, this will be finding like this subsquare muscle. Then we can see that this is acromioclavicular joint. You can see that this is there is peripheral synovium. This acromioclavicular joint arthropathy was there. And in anterolateral scan, if the short axis, we can see that this is suppressor muscle, and the longitudinal long axis, we can see the suppressor muscle like beak like of a bird like this. And anterolaterally, you also scan very important is subacromial subdeltoid bursa, where you can see that this is deltoid muscle, this is suppressor muscle, and in between this muscle there is bursa, subacromial subdeltoid bursa. And this is another picture, the subacromial subdeltoid bursa. And posteriorly, if we scan the transverse of the shoulder, they can see the glenohumeral recess over the posterior glenohumeral recess. This is glenoid labrum. So we can, this is the posterior transverse recess, and then it's a longitudinal scan. If we do the longitudinal scan, they also we can see that it's infraspinatus teres minor, and there is the axillary recess where we also can see the joint recess. So if we want to examine the joint recess of shoulder joint, we can have two sides, actually posteriorly glenohumeral recess and the axillary recess. So now the shoulder pathologies. Rotator cuff, that we have already mentioned, that rototendinopathies are usually the suppressor is the most common. It includes the thickening of the tendons and hypergenitality and heterogeneity. And their thickening of the rotator cuff can result in impingement that we have seen in the first slide, that the two structures, subacromial bursa and suppressor between the acromion process and head of the humerus, there is impingement occur if the suppressor is thickened. So that dynamic assessment for impingement should be performed when tendinopathy is identified. This calcific tendinopathy it is also more common in the suppressor muscle. It is hyperechoic foci within the tendon, and it is less common in the 15% case you can find in the infraspinatus and 5% subsquare muscle. And this tendinopathy actually has four phases. There are resorptive phases. In this case, the patient usually present with intense pain, where vascularized invades the calcified structure, and traumatic response usually ensures. And in this case, in this phase, actually, we can do ultrasonic lavage and aspiration of calcified material. This is supraspinal calcific tendinopathy. We can see the hyperechoic or within the supraspinal muscle. This is supraspinal tendinopathy, that we can see the thickening of the muscle. There is hypoechosis and loss of fibrillation of the muscle. Tendon tear, there may be full thickness and partial thickness tear. There may be articular surface tear, like articular surface tear, bursal surface tear, and intrasubstance tear. And full thickness tear is defined as the tear that communicates from the bursal to articular surface of the tendon. This is the indirect evidence of the rotator cuff tear. That means tendon thinning, cortical irregularities, cartilage interface sign, loss of convex contour of the superficial surface of the tendon, and fluid may be present in the glenohumeral joint. So here you can see the partial thickness tear. There is a tear in the bursal surface, bursal area. There is a partial tear. In this case, we can see the above the humeral head, there is only deltoid muscle. Suppressor muscle is completely tear. So deltoid comes over the humeral head. The pathological subacromial subdeltoid bursa appears thickened more than 2 mm, hypoechoic, and maybe associated with hyperemia that we see over here, deltoid and suppressor muscle. And ultrasound cannot differentiate between septic or aseptic bursopathy. So if we suspect that there is a septic bursopathy maybe there, so we should aspirate and send for culture sensitive gram stain. In bicipital tendon, we can have two kind of findings, like bicipital tendinosynovitis and tendinopathies. So tendinosynovitis is there is a hypoechoic thickening of the bicipital tendon sheath, and there will be some fluid around the tendon. But in bicipital tendinopathy, there will be only the tendon enlargement and heterogeneity, but there is no fluid around it. So in this picture, we can see this is a bicipital tendon and intertendinous sheath. There is a fluid. Here also the longitudinal scan, there is a biceps tendon fluid in the focal part of the around the biceps tendon. There is a concept that if the fluid is present over the biceps tendon at the upper part, it may communicate with the joint and indicates that their joint fluid is present there. Glenohumeral joint, we can see the ultrasonography that like we can diagnose osteoarthritis, posterior glenohumeral tear, glenohumeral joint effusion. And ultrasound also can identify glenohumeral joint osteoarthritis in periarticular cyst line. So in this posterior scan, we can see there is a synovial hypertrophy in the posterior glenohumeral recess, and the glenohumeral is irregular. Hypertrophy osseous changes over there. And this is the synovial acromioclavicular joint. There is the synovial hypertrophy. Lastly, the frozen shoulder. We all diagnose frozen shoulder, but there is no specific ultrasound finding for frozen shoulder. But there are some findings that may suggest there may be a frozen shoulder, like thickening of coracohumeral ligament, increased fluid in the tendon sheath, and increased vascularity. Dynamic imaging of patient with frozen shoulder reveals limitation in sliding movement of the shoulder muscle below the acromion during abduction. Ultrasound is also helpful in ruling out pathology like rotator cuff and bursa. So actually, if a patient comes with frozen shoulder, we can do ultrasound for diagnosis what are the cause under this, but there is no definite ultrasonic diagnosis for frozen shoulder. Here is one of our case that a 50-year-old woman come to us. She's a known case of diabetes and complain of pain for last 2 weeks and give history of fall 2 weeks back. On examination, her glenohumeral joint line is tender. She is painful abduction up to 60 degrees, near test positive, and clinically she was diagnosed as a case of frozen shoulder. When we go for imaging in this case, we can find that there is a tendinopathy of biceps tendon and all the rotator cuff, and there is also you can see there are partial tears from the bursal area. So lastly, I want to share on information that in the USA, their Medicare data concerning that their imaging of muscular disorder concluded that 30.6% of the pathology found on shoulder MRI studies could have been identified using ultrasound. So if we can do ultrasound in properly indicated cases, we can save money. And they showed that in United States, 2006 to 2020, it cost around $6.9 billion for imaging, for using MRI. So if we can use ultrasound in case of MRI, so we can save money and we can diagnose the case easily. Thank you for patient hearing.
Thanks to the speaker. The next speaker is Dr. Shoaib Momen Majumdar. The topic is Unlocking the Secret of the Salivary Glands, Ultrasound Imaging and Non-Invasive Approaches for the Sjogren Disease Diagnosis.
Assalamu alaikum. Good afternoon. My topic is unlocking the secrets of salivary gland, ultrasonography imaging and non-invasive approaches towards the diagnosis of Sjogren's disease. So I want to share a few historical points that Dr. Sjogren, he was a famous Swedish ophthalmologist from Karolinska Institute, and in 1993 for his doctoral thesis he underwent 19 cases and with dry eyes, and among them 13 had arthritis. So he identified that this might be a systemic disease. So we know that it's a chronic autoimmune multi-system inflammatory disease that is characterized by diminished secretion of the lacrimal and salivary glands that is manifested as xerostomia. Xerostomia, that means রুগীরা বলবেন যে আমার মুখ শুকিয়ে আসে, খাওয়ার ফাঁকে ফাঁকে পানি খাওয়া লাগে, অথবা এতটাই শুকিয়ে যায় রাতে মাঝে মাঝে ঘুম ভেঙে আমাকে পানি খাওয়া লাগে। জেরোপথেলমিয়া, চোখ খচখচ করা, বালি বালি লাগা, অথবা কান্না করলে চোখে পানি না আসা, অথবা চোখে টিয়ার সাবস্টিটিউট ইউজ করা, অথবা salivary gland enlargement. So I think that there are some, I want to share some pearls, myths and mistakes in the diagnosis of Sjogren's disease. So we have a common perception that it is an elderly disease, but Sjogren's disease can also involve these children, and 1% of the total Sjogren's population are children, এবং they often do not fulfill the ACR-EULAR criteria because ACR-EULAR criteria is validated upon the adult populations. So criteria fulfill না হলেও পেডিয়াট্রিক্সের ক্ষেত্রে আমাদের এটা হতে পারে। 2 নম্বর হচ্ছে এশিয়ান পিপল অফেন কমপ্লেইন লেস সিকা সিমটমস, এবং এশিয়ান পিপলে যেমন ইন্ডিয়ান স্টাডি আছে আমাদের দেবাশিস ডান্ডা স্যারের ইউলার আপনার প্রেসিডেন্ট, যে 9.3% তারা ড্রাই আই ড্রাই মাউথ কমপ্লেইন করেন। এবং উই হ্যাভ অফেন এ কমন পারসেপশন দ্যাট সিকা সিমটমস না থাকলে শোগ্রেন হতে পারে না। সো দে মে প্রেজেন্ট উইথ মাল্টি সিস্টেম ফাইন্ডিংস লাইক প্রলং পাইরেক্সিয়া অথবা interstitial lung disease, hypokalemia leading to rantubular acidosis, or myelopathy or optic neuritis. So we should have a clue, clinical suspicion that the patient might have Sjogren's disease. Eketre anti-Rho kore we have to confirm. So anti-Rho antibody can be identified 20 years ago before the diagnosis of Zika symptoms. Ebong sheketre anti-Rho kade khetre we should advise যারা রিকারেন্ট হাইপোক্যালেমিয়া ডিউ টু রেনাটিবুলার অ্যাসিডোসিস অথবা সেরিবেলার অ্যাটাক্সিয়া অর ইডিওপ্যাথিক স্ক্লেরাইটিস অথবা ইমিউন থ্রোম্বোসাইটোপেনিয়া অর অটোইমিউন হিমোলাইটিক অ্যানিমিয়া যারা প্রেজেন্ট করেন, এবং দে মে প্রেজেন্ট উইথ ফ্লোরিড আর্থাইটিস মিমিকিং রিউমাটয়েড আর্থাইটিস, অলসো ইনভলভ দি এমসিপি অ্যান্ড পিআইপি জয়েন্টস। শুধু ডিফারেন্স হচ্ছে এক্ষেত্রে ইউরোশন থাকবে না। সো কাম টু দি প্যাথোলজি, আই নো দ্যাট স্যালাইভারি গ্ল্যান্ড are parotid and sublingual glands. Kisu pathology ase we don't decoding time shortage, we are not talking about the pathologies. So what is the importance of ultrasonography in Sjogren's disease? Will it help to identify the diagnosis? Will it exclude the differentials? Will it help in the identification of lymphoma, or can it replace the lip biopsy or the Sjogren autoantibodies? We know that there is a classification criteria, and eketre একটা মেজর পয়েন্ট আছে 3 পয়েন্ট করে লিপ বায়োপসি অ্যান্টিবডি পজিটিভ হলে 3 পয়েন্ট, এবং কিছু মাইনর ক্রাইটেরিয়া আছে আই এবং অকুলার এবং মানে এবং ওরাল ইনভলভমেন্ট বা সেক্রেটারি ফাংশন অ্যাসেস করার জন্য। সো আমরা দেখি যে আওয়ার পপুলেশন সিমস দ্যাট মেজরিটি আর সেরো নেগেটিভ। আমরা যাদেরকে সিমটম পজিটিভ মনে করছি বাট অ্যান্টিবডি করলে আমরা নেগেটিভ পাচ্ছি। আমার Sjogren's পেশেন্টদের 72 জনের মধ্যে মাত্র 9 জনের অ্যান্টিবডি আর পজিটিভ। সো we need lip biopsy, but lip biopsy is not always possible because it is invasive. That's why we require the ultrasonogram. And ultrasonography করার জন্য there is a group, OMERACT group. They have 0 to 3, they have pointed a score, 0 to 3 score. So এই স্কোরের উপর ভিত্তি করে we can identify the Sjogren's disease. So we know that there are 4 salivary glands, 2 parotid and 2 sublinguals. There are also submandibular, 2 submandibular and 2 parotid, also sublingual. কিন্তু আল্ট্রাসোনোগ্রাফিতে parotid এবং submandibularটাই we assess. এই অ্যাসেসমেন্টে এই চারটার মধ্যে if one gland have 0 থেকে 3 স্কোরের মধ্যে যে কোনো একটা গ্ল্যান্ডে যদি 2 score achieve করে, then that may help for the identification of Sjogren's disease. So what is the normal anatomy? It is usually homogeneous. So eক্ষেত্রে ultrasonography we should have some finding that there should be some inhomogeneity and hypoechoic areas. These hypoechoic areas should be small. Large hole it indicates malignancy or lymphoma. They should be non-compressible. And finally, there should not be any blood flow, increased blood flow at the color Doppler imaging. If the flow bar, it indicates also malignancy. So there is a grading. The grade 1, 0 is normal parenchyma. Grade 1 indicates inhomogeneity without hypoechoic areas. What are these? I will show you later. Grade 2, moderate inhomogeneity with focal anechoic or hypoechoic areas, and grade 3 finally severe inhomogeneity with diffuse anechoic or hypoechoic areas. Almost whole of the gland is occupied here. So I'm showing you the pictures. So this parotid gland, this one is submandibular gland, and this one is the normal parenchyma, the gland, this one is the gland, and there is some inhomogeneity, some fibrotic bands. So this one is called the mild inhomogeneity there are some inhomogeneous lines here in the submandibular gland, and it is called grade 1 changes. That means grade 1 bolte gele shudhu inhomogeneity thakbe, there should not be any hypoechoic area. So hypoechoic area gulo kungulo? So these are the hypoechoic areas. There are some hypoechoic areas. এই যে কালো 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 যে এরিয়াটা সেটা হচ্ছে hypoechoic area, আর এই সাদা লাইনগুলো হচ্ছে inhomogeneity. So সাবমেন্ডিবুলার ক্ষেত্রেও একই রকম ফাইন্ডিংস. সো যখন ইনহোমোজেনিটি এবং হাইপোইকুইক এরিয়া থাকবে, দ্যাট উই কল দ্য গ্রেড 2. যখন মাল্টিপল হাইপোইকুইক এরিয়া, যেটা অলমোস্ট পুরা গ্ল্যান্ড জুড়েই থাকে, দ্যাট ইজ কল্ড দ্য গ্রেড 3 চেঞ্জেস. মাল্টিপল হাইপোইকুইক এরিয়াস along with inhomogeneity, that is called the grade 3 changes. So এর মধ্যে if we get any gland having grade 2 changes, that is suggestive of Sjogren's disease. There are some more figures. Due to time constraint, I'm not going there. We see here at least this one is the grade 2 inhomogeneity, along with this some hypoechoic areas. And this one is again the grade 3 multiple hypoechoic areas along with some inhomogeneity. These are the submandibular glands. Time constraint, I'm escaping these parts. So I have to how to hold these scans or perform this. There are two ways. The timber scan along the pinna, and this one is the longitudinal scan. We have to hold in this way along the tragus, in front of the tragus. And this one is the submandibular gland. The longitudinal scan just beneath the submandibular gland, and this one is the timber gland scan of the submandibular gland. So in our BSc department, we regularly perform the salivary gland ultrasonography, and this is one of the patients that who have grade 2 changes. There are some hypoechoic areas along with some inhomogeneity in the left parotid gland, and the diffusely presence of hypoechoic areas in the whole gland in the right parotid gland. So left gland has grade 2 changes, and the right parotid has grade 3 changes. So if anybody have a focal large anechoic area, so we should suspect that the patient might have developed lymphoma, which may have usually a focal appearance, but diffuse may be possible. So this one is a picture showing a large hypoechoic area with increased color Doppler vascularity. So if a single hypoechoic area with increased Doppler changes goes in favor of lymphoma. So another procedure important procedure, we can perform the core needle biopsy. So core needle biopsy, if we suspect lymphoma, we can perform the core needle biopsy to see the sample, to identify, to take the sample for immunohistochemistry and histopathological confirmation. So ultrasonography also helps us to identify lymphoma or suspicious lesions in this way, or also to confirm the diagnosis of sarcoidosis and IgG for related disease like these conditions like sarcoidosis or amyloidosis. So we are also performing some non-invasive. I'm coming towards the end of my presentation. So we are also performing some non-invasive tests for the criteria, to fulfill the criteria of ACR Euler criteria for Sjogren's disease. That is the unstimulated salivary flow. So the patient has to sit, the patient has to be without food for 1 hour, then rinse the mouth, মুখটা কুলি করে পরিষ্কার করে নেবেন, 5 মিনিট বসে থাকবেন চুপচাপ, then take collect the saliva in a pre-wetted tube. আগে থেকেই টিউবের ওজন নেওয়া থাকবে, saliva নেবেন, saliva নেওয়ার পরে এই saliva নেওয়ার পরে তার ওজন. So the calculation should be post-wet, এই টেস্ট টিউবের ওয়েট, প্রি-ওয়েট, স্যালাইভা দেওয়ার আগে কত ওজন ছিল, স্যালাইভা দেওয়ার পরে কত ওজন হয়েছে, এটাকে 5 দিয়ে ভাগ করব। সেটা মিলিগ্রাম পার ml হিসেবে হবে। যদি এটা 0.1 ml পার মিনিট বা তার নিচে হয়ে থাকে, suggestive of Sjogren's disease. We are also performing the Sharman's test, and the Sharman's test is also if it is less than 5 in either eye, that goes in favor of Sjogren's disease. So this is my last slide, and in this slide I think that Sjogren's disease is not uncommon in Bangladesh. So the ultrasonography is a valuable tool because most of the patients seems to be seronegative in our country, to identify the Sjogren's disease, and the OMERACT working groups that means the Sjogren's disease for 0 to 3 scale is a good tool for identifying the Sjogren's disease, and 0 থেকে 3 এর মধ্যে যদি 2 স্কোর করে যে কোনো গ্ল্যান্ডে that is history of Sjogren's disease, and we can perform the core needle biopsy with this tool. So thank you everybody for patience here.
Thanks for the informative talk. So the next speaker is Dr. Farjana Shumi. She will discuss on the case-based discussion on MSK ultrasound finding. I shall request to complete within 8 minutes as per the instruction of the authority.
After each presentation, Professor Syed Atikul Haq advised me to improve my talk by সবসময় বলে থাকে speak slowly, ধীরে বলো. So I don't know, Mabu want me to complete the presentation with 8 minutes. So after this presentation, I think you will be speechless. Anyway, good afternoon, and thanks Bangladesh Rheumatology Society for inviting me. And it's a great pleasure to be here. And I'm afraid that nothing is left for me because each speaker discuss everything. So no conflict of interest, and all the photographs are shown with consent of the patients and no download images used here. So I will show you first how ultrasound help in diagnosis of the patient. So I will show you 2 cases of oligoarthritis. The first case is I will show you how ultrasound help in diagnosis of the patient. So this 20-year-old man had joint pain, oligoarthritis. Started after an episode of diarrhea, and later it was found that he has HLA-B27 positivity. So diagnosis is very simple. This patient has spondyloarthritis. But when I examined clinically, I found that patient has knee swelling and ankle swelling, and it's not very clear that whether it is synovitis or tenosynovitis. But ultrasound showed the difference, that the patient has no synovitis. You can see here that only tenosynovitis is present. It is a transverse section, it is longitudinal section. tibialis posterior synovitis is showing here. And at the same day, this 80-year-old lady presented with oligoarthritis, knee swelling and ankle swelling, and she has comorbidity like she has diabetes, hypertensive, and had recent onset of myocardial infarction, and pre-existing osteoarthritis was there. And you can see that patient has knee swelling and ankle swelling as well. And when I did ultrasound, I found that patient has ankle synovial effusion, and you can see that knee synovial effusion in this image. And later you can see that there is a hyperechoic shadow in between anechoic cartilage, which is very much pathognomic or indicative of CPPD disease. And this imaging, X-ray imaging, also complement the diagnosis by showing that hyperechoic image in the knee joint X-ray. And this man presented with oligoarthritis as well, 50-year-old man, knee swelling and fast MTP swelling. And this image is very clear. In the left hand, you can see that hyperechoic shadow above the cartilage, and MTP showing double contour shadow in MTP joint along with synovial proliferation and synovial effusion. And now I'm moving to some cases of polyarthritis. This 70-year-old lady has had history of hemodialysis for last 11 years, presented with sudden onset pain and swelling of both hands, started from right hand for last 2 weeks. And these are images, the hand swelling And these are X-ray image. I'm not going to discuss on X-ray. There are multiple findings on X-ray. But when we did ultrasound and found that there are hyperechoic shadow in wrist joint synovium, hyperechoic shadow in TFCC complex as well. And in MCP joint, you can see that synovial proliferation and hyperechoic shadow in between the synovium. So this indicates that the patient has CPPD disease, which is very common in hemodialysis patients due to secondary hyperparathyroidism. So this is another case of polyarthritis. This is very common problem among clinicians. This lady presented with polyarthritis with negative autoantibodies, RA anti-CCP, both were negative, and she has normal acute phase reactant. So what is the diagnosis? Is she a case of seronegative rheumatoid arthritis? Is she a case of osteoarthritis? So let's solve the problem by doing ultrasound. So when we did the ultrasound, we found that patient has synovial proliferations in PIP joints, and you can see that there is tenosynovial inflammations, which is indicated by arrow, and flexiotenosinovitis as well. And she has had no history of psoriasis. And in this image, in the left hand, you can see that in PIP joint, there is calcification in the extensor tendon, which indicate extensor tenosinovitis and extensor carpi ulnaris tenosinovitis as well. So we can say that patients might have psoriatic arthritis, as the patient has had tenosinovitis is more than synovitis. So now we can see that how ultrasound changed the concept of the diagnosis. This patient had history of palindromic rheumatism, and all of you know that palindromic rheumatism means that patient had joint pain, and in between period patient should have no findings. RA positive and anti-CCP was positive as well. But when I did the ultrasound at that time, patient had no history of joint pain, and you can see here that the patient has synovial proliferation in MCP joint. So ultrasound just changed the concept that patient has palindromic rheumatism, but persistent synovitis in between the attack. That means that we can diagnose that patient has when we calculate the criteria, ACR criteria, we can put the ultrasound criteria as well, and we can say that patient has rheumatoid arthritis, and we start the treatment with DMRD. This patient has a peritendinous edema as well, because this is a very important finding in palindromic rheumatism. And this article is also showing some important findings in palindromic rheumatism. I will start from the bottom. This is synovitis. This is tenosinovitis, and this is tenosinovitis as well. This is peritendinous edema, and this is periarticular inflammation. So this way, ultrasound can show change the concept that patient had no palindromic rheumatism but relapsing from a persistent arthritis. You can see that here we can see that how ultrasound complement the diagnosis. I think Dr. Shobha Mojumdar nicely described it. This is a 10-year-old girl, had bilateral parotid swelling and positive anti-SS antibody. You can see here that multiple hypoechoic lesion in parotid gland, and this indicates that patient has Sjogren disease. This is another picture, and this is the Omer cut grading. I'm not going to show you in details because this has already been discussed. And how ultrasound help in the diagnosis of rare cases. Because this lady presented with sudden onset pain and swelling of volar aspect of the wrist, and ultrasound is showing that calcification along the flexure tendon. And this lady has had pain, sudden onset pain of index finger, and this ultrasound showing calcification along the tendon and no synovial inflammation. So these two cases actually was acute calcific periarthritis, and this is a very rare case. This was described by Professor Duplé in 1817. It does not involve the joint proper and may assist in differentiating entity from other inflammatory and erosive arthritis. And calcification associated with CPPD arthritis, as you have seen in my previous cases, is usually more linear and elongated than those seen in acute calcific periarthritis. The calcification in acute calcific periarthritis is small than CPPD disease. How ultrasound help in diagnosis of vasculitis and also help in monitoring activity and remission of the disease. There are several studies in Takahashi arteritis that is correlates with the ITS scoring, which is clinical scoring to see the activity of Takahashi arteritis. And you can see that vessel inflammation, vessel wall thickening, both anterior and posterior wall, and macaroni sign as well. So intima-media thickness of the right common cataract is here it is 0.17 to 2.6 millimeter, when the normal value is 0.06 millimeter. And this is also showing the intimal medial thickness. So I'm moving to the more cases. This patient was referred to see whether that this patient has nodal osteoarthritis or psoriatic arthritis. You can see that patient has distal interphalangeal joint swelling and pain. So let's solve the problem. So when I did ultrasound, that the mind was that patient has DIP, nodal osteoarthritis. So CMC joint is showing some irregularities, erosion and osteophyte as well. So whether the diagnosis is nodal osteoarthritis. So move to the next slide. So when I did ultrasound in MCP joints, you can see that the synovial proliferations, I compare with the normal right side and left side. In left side it is normal, and right side you can see synovial proliferation in MCP joint. And the index right middle finger is showing synovial proliferation, some bony spur which is consistent in enthesophyte, and some extensor tendon inflammation as well. In the next slide, you can see also the bony spur, synovial inflammation, and extensor tendon inflammation. And in this slide, you can see the DIP joint is showing some bony proliferation, bony spur, synovial inflammation, and extensor tendon inflammation. Here you can see that extensor tendon inflammation by hypoechogenicity around the extensor tendon. And in this slide, you can also find that patient has bony proliferation, synovial inflammations, and extensor tendon inflammation. And nail plate also showing that increased nail plate thickness in this patient. And this is another slide showing collateral ligament inflammation. You can see here the ulnar collateral ligament is thickened, irregular, and slightly inhomogeneous, indicate collateral ligament inflammation, which is common in psoriatic arthritis. And this slide is showing sagittal band thickening. You can find in the, I will always compare the normal and abnormal side. This will help you to find the findings. This will help you to evaluate the findings and for the diagnosis. In the right side is normal, sagittal band, I'm indicating with the arrow. In the left side, sagittal band is thickened. And this is another image which is showing thickened sagittal band. So the problem is now, I think, become easier that patient has had psoriatic arthritis. Although patient had no history of psoriasis, no family history of psoriasis, negative autoantibodies, negative autoinflammatory markers, we can say that patients might have psoriatic arthritis. So this is another case I encountered. This is my last case only 2 days back. This 27-year-old lady, and I thanks to Professor Roshanara Shapna for sending this case. This 27-year-old lady had sudden onset of knee joint pain, which is persisting for only last 3 weeks. No other significant present or past history. Started anti-tubercular chemotherapy just 1 month back because of diagnosis of the ocular tuberculosis, and found that patient has low titer anti-CCP positivity. Only the titer was 25. HLA-B27 report was pending. So what is the diagnosis? And I would like to mention the serum uric acid level was very high. It is 11.1 milligram per DL. And the ultrasound solved this problem. This is synovial inflammations and mild synovial proliferation. And this image is showing that hyper-equi shadow above the cartilage. And you can see the right hand picture is normal. And it is compared, this is my knee is normal. In the left, right, normal. You can see that this is my knee. It's normal because in above the anechoic cartilage is very sharp should be, but in the patient there is hyperechoic shadow above the cartilage. So this image is very clear that patient has acute gouty arthritis due to anti-tubercular chemotherapy. So I would like to conclude by giving some take-home messages that is more sensitive than clinical ultrasound examination. Ultrasound help in early diagnosis, help in classification of the disease, monitoring, and also help for guiding of injections. With all these, I would like to conclude. Thank you. Thank you all. Sir, আপনি ছিলেন না আপনাকে দিয়ে শুরু করেছিলাম because I told that after each presentation Professor Atik advised me to improve my talk by advising me that speak slowly, but this time Mahu want me to complete the presentation within 8 minutes.
Thank you, Abba, for your nice deliberation. So I shall invite the last speaker of this session, Dr. Muhammad Abul Kalam Azad. He will talk on MSK ultrasound guided biopsy. Sir.
Good evening, everybody. I feel honored to be here. Thanks the organizer of PRS for selecting me the speaker of on musculoskeletal biopsy. I would like to express my thanks and gratitude to Professor Minhaj Rahim Chaudhary. He is the pioneer of synovial biopsy. And also I would express my thanks and gratitude to Professor Syed Atikul Haq, Professor Nazrul Islam sir for continuous inspiring us. And I would like to express thanks and gratitude to Professor Ingrid Molar. He's from Spain. He's the main teacher of synovial biopsy. This is the biopsy team of our department. This is the content of our discussion, indication of synovial biopsy, our experience, and technique and procedure, histological finding, and adverse effect of synovial biopsy. Lastly, conclude. Synovial biopsy is the procedure where sample of synovial tissue or synovial membrane is taken. First of all, we should know the structure of the synovial membrane, where it is lies, what is the structure. So, it is usually done synovial in small joint like metacarpophalangeal joint, metatarsophalangeal joint, medium joint such as wrist and ankle joint, large joint, all large joint. Normally, it is not done in established case of rheumatological disease, but it is done only in suspected or unexplained monoarthritis or polyarthritis. History, it is start of 1930 by during arthroplasty, and lastly 1997 ultrasound guided synovial biopsy. This is the indication of synovial biopsy. Infective cause to differentiate between bacterial, fungal and protozoal disease. Also autoimmune and degenerative disease, rheumatoid arthritis. Even we can differentiate RD rheumatoid arthritis and established rheumatoid arthritis by synovial biopsy. Spondyloarthritis, psoriatic arthritis, also osteoarthritis. Crystal disease, we have discussed details by Sumi as gout, pseudo-gout. If we do not found any crystal by synovial fluid analysis, you can also do synovial biopsy. Metabolic and inherited disease, hemochromatosis, ochronosis, Wilson's disease. Sometimes amyloidosis can be diagnosed by synovial biopsy. Unexplained polyarticular arthritis with bilateral carpal tunnel syndrome and suspected case of amyloidosis, we can do biopsy from joint. Sarcoidosis, tumor of the synovium, bilionodular synovitis, osteosarcoma, we can diagnose by synovial biopsy. Evaluation and treatment and follow-up of the disease. This is the interpretation of the synovial biopsy, intense granulocyte interpretation. First of all, we should know synovial membrane. There are the two layers of synovial membrane, intimal layer and subintimal layer. Intimal layer consists of two cell lines. Number one, macrophage. Number two, fibroblast-like cell. And a subintimal layer, there is also a fibroblast, neutrophil, and sometimes macrophage in the subintimal layer. If we intense granulocyte in the intima and subintima, we can diagnose septic or crystal arthritis, crystal arthropathy. Sometimes in synovial biopsy, we can do CD15. It is the specific for septic arthritis sometimes. If we found lymphoid follicle in the subintima, also plasma cell, fibrin deposition, we can diagnose rheumatoid arthritis, SPA or psoriatic arthritis. Fragment of bone and cartilage with giant cell can differentiate degenerative arthritis. Heavy pigment heavy iron poisoning, pigmentation, such as hematorosis, hemochromatosis, pigmented villonodular synovitis, we can diagnose by biopsy. Granulomatous disease, tuberculosis, sarcoidosis, fungal infection by various stain and culture also. Our experience, we did 10 biopsy in our department. One is small joint, one hip joint, one MTB joint, one elbow joint, 4 knee joint, and 3 ankle joint. We found 4 tuberculosis among 10 patients. And one patient, we get not find any synovial tissue, maybe problem in technique or transport system. এখন আমাদের স্যাররা আছেন অনেক সময় প্রশ্ন করেন যে মনো আর্টিকুলার রোগী কিভাবে আসলে কিভাবে আমরা অ্যাপ্রোচ করব, বিশেষ করে স্টুডেন্টদের জন্য বলছি। এটা সাধারণত আমরা ডিটেলস হিস্ট্রি এক্সামিনেশন এবং রিলিভেন্ট ইনভেস্টিগেশন করে আমরা একটা ডিফারেন্সিয়াল ডায়াগনোসিস সেট করি। এক্ষেত্রে 50 years old man cultivator, pain and swelling the left ankle joint for 5 months. How can evaluate the patient? Lastly, আমাদের diagnosis ছিল clinical diagnosis, tubercular monoarthritis, X-ray of the left ankle joint calcaneus bar, X-ray sacroiliac joint was normal, ultrasonography of the left ankle and subtalar joint synovitis. This is the longitudinal view of the ultrasonography of the ankle joint. This is the grade 3 synovitis with power Doppler. There is a synovial fluid in the ankle joint. This is the histology of our case. This is the tubercular arthritis. Another scenario, right elbow pain for 3 months without any trauma. Again, details history and meticulous examination. Details history include all the joint involvement, history of the other joint, any comorbid disease, and meticulous examination and relevant investigation shows this is the biopsy specimen, last one. Biopsy specimen. This is the histological feature. This is multiple, again another slide shows multiple granuloma. This slide shows tuberculosis. This slide shows synovial membrane, structure of the synovial membrane. This structure, macrophage, another fibroblast, adipocyte, and mast cell. This is mast cell. This is the crucial question. This figure shows crucial questions: why, when, what, who, where, and how synovial biopsy can be done. Who should undergo synovial biopsy? Suspicious case of atypical monoarthritis or polyarthritis. Therapeutic purpose. When should be done? In clinical purpose and research setting. Why should be synovial biopsy done? Classification of early undifferentiated arthritis. Classification of the early undifferentiated arthritis. Very much useful. Disease severity, stratification of patient of RA. Identification of predictor of response and development of synovial tissue targeted therapy. What information you can get from synovial biopsy? We can differentiate infectious disease, non-infectious disease, tumor, deposition disease, and some autoimmune disease, so inherited disease. Where should be synovial biopsy performed? Biopsy performed in affected joint if non-traumatic. In monoarthritis, inter-joint heterogeneity, intra-joint variability. If we do the synovial biopsy in the same joint, we can find histological different structure, different cytology in same joint. Also in two joint, if we do synovial biopsy in the two joint, we can find different histological finding. For this region, this rheumatoid arthritis is called heterogeneous autoimmune disease. Heterogeneous autoimmune disease. That is presentation is heterogeneous. This is the why again we can tell cerebral biopsy we can clinical and research purpose. Early arthritis we can diagnosis. In research purpose, early arthritis, new drug evaluation of treatment response. Clinical, granulomatous disease, non-granulomatous disease, crystal disease, already mentioned previous slide. There is a three method for cerebral biopsy. Number one, direct. Number one, blind method, blind. Initially it was done by blind method. Then again, direct vision and indirect vision. Direct vision during surgical procedure and arthroscopic. And guided two types, ultrasonography guided and another is fluoroscopic guided. We emphasis on the ultrasonography guided cerebral biopsy. It helps in the direct view of cerebral membrane which reveals primary diagnosis. This is the arthroscopic instrument. This is the arthroscopic finding of macroscopic finding of arthroscopic finding of the biopsy. Disadvantage of arthroscopic finding. Disadvantage. Invasive. It is invasive. Expensive. Not widely available. Time consuming. Technical complex. Why cerebral biopsy? Because it is non-invasive, inexpensive, available, and time is not required so much. Technique is simple. Ultrasonic cerebral guided biopsy, the procedure is indirect view, not direct view. The skin disinfected by povidone or any procedure, draping should be given. The probe should be covered by sterile gel and sheath. Ultrasound machine, sterile trolley should be available. Synovitis score mild, moderate, severe by grayscale and power Doppler. Easily 2 to 5 ml anesthetic agent is required in small joint and 10 to 15 ml anesthetic required in large joint. There is the longitudinal ultrasonic image to detect needle and appropriate predetermined site of the biopsy. Then length and angulation of the needle should be measured. Biopsy to be retrieved per procedure. Time usually required 70 minutes. This is the ultrasonogram instrument. Needle, anesthetic agent, scalpel, coaxial sheet, biopsy needle. This is biopsy needle. This is biopsy needle. This is the site hip joint. We know this is the hip joint of ultrasonogram. This is the cerebral hypertrophy. This is the needle. Before taking biopsy and after taking biopsy, this is the specimen. This is the macroscopic appearance of the sample. This is the graphical presentation of the specimen. This is the whole length, whole part of the sample. This is the length and this is the breadth. Slide to move. This is the histological finding. For preclinical purpose, more than six fragments are sent for paraffin embedded and more than 5 for microbiology. The synovitis should be scored by histopathologist, hyperplasia of the intima, stromal cell density and intensity of the inflammatory cell infiltration. The major contraindication, this is the major contraindication, major systemic skin infection, coagulation disorder and patient not informed. Potential pitfall of cerebral biopsy, quantity insufficient for diagnosis, avoidance of antibiotics before suspected septic arthritis. This is the adverse effect. This is the adverse effect depend on some local structure, muscle, nerve, vein, artery. If injury this may cause this side effect. In conclusion, ultrasonogram cerebral biopsy is safe and well tolerated beside the procedure that is established in Europe and rapidly growing in United States of America. In Bangladesh, recently started cost-effective, simple, minimal hazard of cerebral ultrasonogram cerebral biopsy in the Department of Rheumatology for differentiating monoarthritis. Thank you everybody for patient hearing.
Thank you very much. It was a wonderful session, a complete package on MSK ultrasound. As we are running short of time, we can allow 1 or 2 questions from the audience.
So I have actually a comment or a very basic message to the audience. So we are always telling hyperechoic, hypoechoic, mid-echoic, etc. terms which we are using. So you know that in the abdomen, the liver is the reference. Here we are, using the liver as the reference. But what about in the musculoskeletal tissue, in the vascular tissue, and in the salivary glands? So that needs to be discussed because this is the very basic, concept. So in the musculoskeletal structures, this is the subcutaneous fat. This is the reference. Bone is more echoic than subcutaneous fat. Synovium is less echoic, so it is hypoechoic or anechoic. So this is the reference. In Takayasu arteritis, you see that the comment is mid-echoic wall thickening. What is mid-echoic? So here the intima and the adventitia are the references. Intima is anechoic, adventitia is hyperechoic, and in between them is mid-echoic. So there will be mid-echoic echo appearance of the intima media. So this is, and whatever salivary glands. So this is the thyroid gland is the reference, but if thyroid gland is diseased, for example thyroiditis, then you have to compare it with the muscle surrounding muscle surrounding the salivary glands. The salivary gland will always be a bit hyperechoic than the surrounding muscles. So so that has to be borne in mind. Thank you.
Thank you for the nice supplement. If no more questions there from the audience, may I now invite our chairperson of this session, Professor AFM Nazmul Islam, to say a few words on today's presentation.
Bismillahirrahmanirrahim. I like to thank the Society of Medicine Bangladesh for their initiative to disseminate the knowledge about ultrasonography of musculoskeletal system in this region, in this part of Bangladesh. I hope this will encourage the practitioner of this region to know about the ultrasonography of muscular system. We came to know that the ultrasonography of muscular system can detect, can be used to evaluate the normal anatomy of the muscular system, can identify the pathology, can differentiate the pathology, can monitor and evaluate the treatment, and to assess the disease severity. So it has got a versatile use in clinical medicine and rheumatology. So from my part, I can request the Society of Medicine, please arrange a certificate course of ultrasonography of muscular system for the fellows or the interested peoples. Then this new technology can be used for the peoples of different parts of Bangladesh other than the Dhaka city. So with these few words, I'd like to conclude. Thank you, everybody.
Thank you, sir. Now I want to invite Dr. AKM Johir Ahmed to say a few words in this presentation.
Bismillahirrahmanirrahim. Honorable co-chairman, distinguished teachers, learned audience, especially Atik sir, Professor Nazrul Islam, Professor Minhajur Rahim Chaudhary. Actually, we all are tired now. জ্ঞানের কথা এমনি বারবার বললে ধৈর্যচ্যুতি হয়, রবীন্দ্রনাথের সেই কথা। সুতরাং সকাল থেকেই আমরা জ্ঞানের কথা শুনছি, আমার মনে হয় আর কেউ শুনতে চাবেন না এখন আর। তবুও আমি ধন্যবাদ জানাচ্ছি যারা প্রেজেন্ট করেছেন, প্রত্যেকেই খুব মানে ভেরি নাইসলি দে হ্যাভ প্রেজেন্টেড দেয়ার পেপার্স। তারপরে একটা বা দুটা কথা একটু বলতে চাই, যেহেতু সুযোগটা আসলো, সুযোগ তো আসে না। Everybody, every presenter said the advantage, disadvantage, etc., etc. What is the beauty of ultrasound? This is the question. There is MRI, CT scan, but what is the beauty? It has excellent beauty. It is cheap, side effect free, easy to perform, and this is a dynamic study. Like in every joint we can move and we can see. This is the benefit. And other benefit, it is real time. Not like the X-ray, CT scan or MRI. সকালে করলাম রাতে report, not. I am performing now, I am reporting now. This is real time. And we can compare between the pathological side and non-pathological side. So this was my topic. And another thing, minded, this is the scan of different planes like sagittal, coronal, axial. Minded, who will perform the musculoskeletal ultrasound, they must know this is the sectional anatomy. They should know sectional anatomy, not the conventional anatomy. Where is the origin and where is the insertion? It is not important for me, because we do slide in different planes. So minute anatomy should know who practices this musculoskeletal ultrasound. But in a conventional sonologist, like abdominal or pregnancy, he or she deals with the gross organ, liver, spleen, kidney, etc. etc. But I, who practice the musculoskeletal ultrasound, my subject with minute things like ligaments, capsule, synovium, nerves, bursa, fossa, calcification, micro and macro, anthocyte and anthocophytes, like this. So it is tough job, very tough job, karon everything is black and white, like সাদা কালো television. Every structure is either white or black or mixed echogenic, in between this. So good anatomical knowledge must be gathered, otherwise no one can do this. And everybody, they have described elaborately. I thank to everyone. Dr. Masood, second speaker, most probably, he said, can we hear ultrasound? Can we hear ultrasonography? He said, no, this is correct and this is incorrect. Because echocardiography, ultrasound of the heart, we can hear hissing sound because it is Doppler ultrasound. So I request everybody to know Doppler ultrasound who will practice the musculoskeletal ultrasound. And time is very short, so I don't say anything. And again, I thanks to every learned person. Thank you. Thank you.
আচ্ছা ডিয়ার অডিয়েন্স, তাহলে এখন আমাদের লাস্ট সেশনটা হবে আরেকটি অত্যন্ত আকর্ষণীয় রেফেল ড্র। অ্যান্ড তার আগে আমি শুধু খুব ছোট্ট করে একটু এই ইন্টারভেনশন রিউমেটোলজি সম্পর্কে একটু একটা মিনিট সময় নিব। আমাদের বিএসএমএমইউতে আমরা এই ইন্টারভেনশন রিউমেটোলজির যাত্রা শুরু করি 2014 সালে। আমাদের অধ্যাপক সৈয়দ আতিকুল হক তখনকার ভাইস চ্যান্সেলরকে সামহাও কনভিন্স করে টোরে একটা ফান্ড জোগাড় করেন এবং মেশিন ওয়াজ পারচেজড। এটা দেওয়ার পরে তারপরে আমরা আমাদের ডিপার্টমেন্টে এটা হাঁটি হাঁটি পা পা করে আমরা একটু যাত্রা শুরু করি। তো নাজমুল ভাইয়ের এই কথাটা আমার খুবই ভালো লাগলো যে যেহেতু এই আল্ট্রাসাউন্ড রিলেটেড অনেকগুলো জিনিস দ্রুত কিন্তু এগুচ্ছে, তো এইটার সাথে কোপ করার জন্য আমার কাছে মনে হয় ইন্টার্নিস্টদেরও এগিয়ে আসাটা খুব জরুরি। এখন যেমন আমরা এই দীর্ঘদিনের প্রচেষ্টায় প্রায় 6টি আমরা ইন্টারন্যাশনাল কোর্স আল্ট্রাসাউন্ড কোর্স আমরা ঢাকায় আয়োজন করি এবং আমাদের ইউরোপের শীর্ষস্থানীয় কয়েকজন ফ্রেন্ড এরা আমাদেরকে খুব সহযোগিতা করছে, খুবই ফ্রেন্ডলি, খুবই হেল্পফুল। সো দে আর কামিং। এবং এই জায়গায় আমেরিকা থেকে ইউরোপ কিন্তু এগিয়ে আছে। প্রায় সব জায়গায় আমরা দেখি যে আমেরিকানরা একটু এগিয়ে থাকে, এই জায়গায় কিন্তু ইউরোপিয়ানরা একটু এগিয়ে আছে এই যে এই আল্ট্রাসাউন্ড রিলেটেড। তা আমরা শুরুটা হলো আমাদের এই জয়েন্টে আল্ট্রাসাউন্ড, টেন্ডন ইত্যাদি ইত্যাদি। তো এখন কিন্তু পরিধি বাড়ছে। এখন যেমন আমরা আমাদের আজকে প্রেজেন্টাররা বিভিন্ন জায়গাগুলো দেখিয়েছে যে আমরা এখন সেলিভারি গ্ল্যান্ডগুলো দেখতে পাচ্ছি, শোগ্রেন সিনড্রোম ডায়াগনোসিসে হেল্প হচ্ছে অ্যান্ড আদার্স। তারপরে আমরা এখন বায়োপসিতে গেলাম এবং এরও বাইরে আমরা কিন্তু এর মধ্যে ওই যে আমাদের পলিমায়োসাইটিস, ডার্মাটোমায়োসাইটিস এই রোগীগুলো আমাদের ইন্টারভেনশন রিউমেটোলজির আওতায় আমরা একটু মাসেল বায়োপসি নিজেরা একটু করার কথা চিন্তা করছি। ভেরি ইজি। আমাদের ইভেন নেপালি কলিগরা দে আর ডুইং ইট, দে কেম টু বাংলাদেশ। তারপরে আমরা এখন এই যে শোগ্রেনকে আরও নিশ্চিত করার জন্য লিভ বায়োপসি। সো ইন্টারভেনশন রিউমেটোলজি আমার মনে হয় এগুলো ইন্টার্নিস্টরাও এভাবে চিন্তা করতে পারেন ডেফিনেটলি। আর আমাদের যেমন এতদিনের প্রচেষ্টায় এক ঝাঁক তরুণরাও ধীরে ধীরে এগিয়ে আসছে। তা আজকের এই প্রচেষ্টাটা কিন্তু ওটার জন্য যে আরও বেশি যাতে উৎসাহিত করা যায় সঠিক জায়গা সঠিকভাবে এটা দেখার জন্য। তা আমি এর জন্য ধন্যবাদ দিব আজকে যারা প্রেজেন্টার ছিল এবং একেবারে এবং এরা অত্যন্ত নিবেদিতভাবে কাজ করছে আমাদের ডিপার্টমেন্টে। আমরা যারা আছে আমাদের যারা আজকে প্রেজেন্ট করলো, মাসুদ, আজাদ, শোয়েব অ্যান্ড দেন আরিফ, নাহিদ, তারপর আহমেদ নিজেও এরা করছে। এবং বাইরে আই কেম টু আমরা যেমন ফারজানা সুমি ইজ ডুইং ইট ইন স্কোয়ার, ভেরি গুড। তারপরে জাহিদ আমিন, হি ইজ ভেরি ইন্টারেস্টেড, পুলিশ হসপিটালে হি ইজ ট্রাইং ইট, হি ইজ ডুইং ইট টু সাম এক্সটেন্ট। কামরুজ্জামান আছে টাঙ্গাইলে, ও করছে। আর রাব্বানি চেষ্টা করছে ইয়াতে রংপুরে। সো হ্যাঁ, তানভীর, তানভীরের কথা ভুলেই গেলাম। ও তো আমাদেরকে বেশ কিছু অনেক সময় বেশ কিছু সহায়তা করছে বিভিন্ন ধরনের তথ্য দিয়ে, ইনফরমেশন দিয়ে। অ্যান্ড হি ইজ শোয়িং ভেরি মাচ ইন্টারেস্টেড। ভেরি গুড তানভীর, যে ও ইন্টারেস্ট পাচ্ছে, দ্যাটস গুড। তো এই এবং আমি এর জন্য আরও যারা এখনো আমি এর জন্য আজকে জোর করে করে ফোন করে ওকে কেউ রেসিডেন্টরা আমাদের পালানোর চেষ্টা করছিল কিনা আমি জানি না, এদেরকে ফোন করে আনার চেষ্টা করছি যে আল্ট্রাসাউন্ড প্রোগ্রাম শুরু হবে, তোমাদের অবশ্যই ওখানে থাকা লাগবে। সো যাই হোক, আমি বলবো যে যারা এখানে সিলেটের জুনিয়র কলিগরা তারাও যাতে একটু প্রথম দিকে কিন্তু কিছুই বোঝা যায় না, বাট রিয়েলি ইটস হেল্পফুল। এবং আমরা আরও করার চেষ্টা করেছি ওই যে লাংয়ের কিন্তু এখন আমাদের কেউ একজন দেখিয়েছে তো আজকে না। সো লাংয়ের আমাদের ইয়ের বোধহয় কিছু ইয়ে ছিল, সো নাহিদের। তো লাংয়েও কিন্তু আমরা এখন প্লুরাল ইফিউশন তো ডেফিনেটলি। তারপরে আমরা ILD, interstitial lung disease, and pulmonary infarct, and also the pericardium ইত্যাদি এগুলো কিন্তু দেখা যায়। So ultrasound, if you have a probe and if you are enough expert, then you can really diagnose, and it is very simple, within a very short period of time it can be done. তো ঠিক আছে, সবাইকে ধন্যবাদ। আমি আবার একটু মাহবুবকে বলবো বাকি অংশটা শেষ করতে।
So it's now time for giving the memento and certificate. I shall invite the speakers of the session to come one by one to receive memento and certificate from the chairpersons. First, Dr. Muhammad Nahirujjaman Sajjad. Dr. Muhammad Masudul Hasan. Dr. Muhammad Ariful Islam. Next, Dr. Shoaib Momen Mojumdar. Dr. Shoaib Momen Mojumdar. Next, Dr. Farjana Shumi. Dr. Farjana Shumi. Next, Dr. Muhammad Abul Kalam Azad. Thank you, sir. Now I shall request Professor Minhaj Rahim Chaudhary, sir, to give certificate, to hand over certificate to two of our chairpersons, Professor A.F.M. Nazmul Islam and Dr. A.K.M. Johir Ahmed. Officially in this program, moderator was Professor Minhaj Rahim Chaudhary, so I shall request the chairpersons to hand over the certificate to official moderator of this session. Thank you, sir.
Dear participant, the last session is the most exciting one. The event of the day, raffle draw. This, coupon, না এটা স্যার অনলাইনে ছিল, মানে এটা রেজিস্ট্রেশন করতে হয় যাতে